So welcome to this teacher training entitled Race and Public Health in Latin America. Can people hear me? Those of you with your cameras on, can I get a signal? Okay, great. This event is the Fall 2020 teacher training hosted by the University of Michigan Center for Latin American and Caribbean Studies, or LACS. LACS is a Title VI National Resource Center funded by the U.S. Department of Education, and we thank them, of course, for their support for this initiative. My name is Tim Lorick, and I'm Outreach Coordinator for LACS at the University of Michigan. Before we begin with our first speaker, Alexandra Stern, I want to run through just a few logistics of the event with you. So time. The event will run from right now, 4:30 until 8:30 p.m. We have 4 speakers lined up. We've asked each of them to prepare about a 30 to 40-minute presentation, and then we will leave time for questions and discussion afterwards, and hopefully allow time for a quick break even in between each of the sessions. We're hosting this event as a Zoom meeting, as you can obviously tell. We decided to do this rather than a webinar in order to facilitate a more robust discussion about teaching, hopefully after each of the presentations. Because it's a Zoom meeting rather than a webinar, we do ask all of you to mute your microphones if you've not already done so. And please only unmute yourself when you are speaking to limit distractions for the presenters. We'll limit questions and comments to after each presentation in order to minimize disruptions and confusion in this remote format. So take a moment now to locate the chat function on the side. Most of you already know everything there is to know about Zoom by this point, but nevertheless, you may submit questions, comments, or concerns to me directly through the chat. Recording. You probably noticed we are recording this event, and we will send you the recording of the event after the fact for your future reference. So hopefully that is useful to people. Teachers. If you are a K through 12 teacher in the state of Michigan, you are eligible to receive up to 4 sketch credits for your attendance and participation in this event. I will take note of attendance throughout the event, and I will submit the sketch information for every teacher who sends me their signed form. So those of you who are teachers in the state of Michigan should know what I'm talking about. If you are a teacher in Michigan and you don't know what I'm talking about, please send me an email, and I will make sure that you have everything you need to get your professional development credits. Okay, oh, that form that you need, I sent that in the email yesterday, so hopefully everyone saw that as an attachment. Schedule. I will introduce each of the speakers before their individual presentation rather than introduce everyone now. But just very briefly, our schedule is as follows. First, we'll have Dr. Alexandra Stern, who will begin with a presentation called Creating and Addressing Racial Health Inequalities in Latin America, an overview. Then at 5:30, Dr. Victoria Langland will follow with her talk, followed by Alana Rodriguez at 6:30, and Dr. Stephen Palmer will wrap things up at 7:30. And I will introduce those subsequent speakers more thoroughly when their time comes. Are there any questions that need addressing right now before we begin? All right. So in that case, I will introduce our first speaker. Dr. Alexandra Stern is the Carol Smith Rosenberg Collegiate Professor in the Department of American Culture at the University of Michigan. She also holds appointments in the Departments of History, Women's Study, and Obstetrics and Gynecology. Stern directs the Sterilization and Social Justice Lab, an interdisciplinary, multi-institutional research team that is reconstructing and analyzing the history of eugenics and sterilization in 4 U.S. states, Michigan, North Carolina, Iowa, and California. Dr. Stern's research has focused on the history of eugenics, genetics, society, and justice in the United States and Latin America. Through these topics, she has explored the dynamics of gender, sexuality, race, ethnicity, disability, social difference, and Reproductive Politics. Among Dr. Stern's books is the prize-winning Eugenic Nation, Faults and Frontiers of Better Breeding in Modern America. So without further ado, Dr. Alexandra Stern.
Well, thank you for that very kind introduction. I really appreciate it. I assume everyone can hear me. If you can't hear me or see me, put a note in the chat. I assume everyone can use the chat, so we're good. Okay, you can never quite tell what's happening out there on the other end. You know, I'm sitting in my office giving this talk. Hello, everyone. It's nice to spend this Thursday afternoon with you. So what I'm going to do now is I'm going to go ahead and share my screen. Okay. So again, thank you for the invitation to present this talk. I did tweak the title a little bit to make it even more of a general overview. The purpose of my talk is to provide a sweeping and, although not comprehensive, overview of public health and global health in Latin America over the past 2 centuries, touching on some of the key themes and allowing us to understand some of the key historical contexts that got us to where we are today. What I hope is that this talk will provide enough kind of general framing and also specific details to be helpful for you, and also that it will provide a backdrop for the really interesting talks that will follow mine as well, where we have researchers who are doing really interesting focused research topics in various parts of Latin America. So one of the places I like to start when thinking about health and public health is simply with definitions. And I think it's important to start, it's always useful to start with the World Health Organization Constitution. This takes us back to 1948, after the end of World War II, when international meetings were happening and countries were gathering to think about what health would mean in a post-war world. And this is a definition that still resonates very much today. And I share it with you so that we can think about the ways in which health addresses both the diseases that need to be combated and maybe potentially eliminated, as well as the more positive elements of health in terms of well-being. So well-being is a word that we use a lot when thinking about health and public health, because it's about holistic well-being. So the definition from 1948, as you see on the screen, is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So really the idea is health is not just about getting rid of the latest infectious scourge or combating one particular ailment, but it's about the totality of the well-being of both individuals and the population at large. So that's health. How do we define public health? So public health takes up that collective element that I just mentioned and expands it to thinking at communities writ large and societies writ large. And there is a link, and I will be happy to share this presentation with you later if you like it. I have a link to the American Public Health Association's discussion of what public health is, and it's more lengthy than what I've included here, but you see some of the same themes. So public health promotes and protects the health of people and the communities where they live, learn, work, and play. While a doctor treats people who are sick, those working in public health. So now they're really talking about public health workers. So who are the folks who are on the ground? It might be the epidemiologists, or you'll see some of the key actors in public health in my slides to come, visiting nurses, that prevent people from getting sick or injured in the first place. And they promote wellness by encouraging healthy behaviors, which would be behaviors such as not smoking, and if we think of getting exercise, and of course there's the structural dimension, having access to nutritious food and healthy work environments. So keep those definitions in mind as I move through the talk. And also, the definitions themselves were produced in a particular time period and in a particular historical moment. And I think it will become clear as I speak, why that is important to have to be aware of. So, okay, another kind of overview slide, thinking about Latin America and the Caribbean. Maps are always handy. I think it's good just to remind ourselves of the vast region that we're talking about that stretches from Mexico, Central America into South America, as well as the Caribbean. So there are about 650 million people live in Latin America. The largest Latin American country is Brazil in terms of both land and population, with about 20 million people, followed by Mexico. And then there's a wide variety, across the different countries, with, for example, Suriname being in the far northern part of South America, with several million, and Honduras with a population that's right there in Central America, with a population of less than 10 million. So when we talk about Latin America and the Caribbean, I think it's great and interesting to study it as an entire region. However, it's not monolithic, and there's a wide range of both histories, cultural differences, and experiences with health and public health. So, what do we look at when we look at health and public health in Latin America over the past 200 years? And this is where we get into thinking about the relationship, for example, between politics and health, government and health. So, there would be a few kind of key actors to think about when we're thinking about this history. The first is the government's policies, laws. The next would be health actors themselves, like public health actors and doctors, as well as theories and changing understandings of health. Because I just shared with you this definition from 1948, our post war definition, which is very resonant today. However, that understanding has changed over time, and it's changed as scientific knowledge has evolved with relation to health. What causes disease? What cures disease? Um, and also understandings of what and developments of what treatments can be used. And then also what responses are to emergent diseases. And at the end of the talk, I'll go a little bit into COVID and what COVID looks like in Latin America. And then finally, obviously, key actors are individuals themselves, everyday people who are those who are experiencing health conditions and engaging with these other actors. So I'm not going to spend that much time talking about the colonial period in Latin America, which is really fascinating. It's not my area of expertise. I've studied it to some extent, understanding in particular the role of, for example, religious institutions, particularly Catholic or Dominican Jesuit institutions that played a big role in setting up some of the first hospitals in Latin America, as well as the absolutely essential history of indigenous communities and naturopathic medicine, and indigenous healing traditions. Those still are very much alive and well today and have morphed in complicated ways. But where I'm going to start really is in the kind of mid 19th century. So we're talking about 1850s or 1860s. By this point in the almost all the Latin American countries that I just showed you in the previous slide, those countries had attained independence from, for the most part, Spain, but also eventually Brazil, Portugal, Brazil from Portugal, as well as in the Caribbean, from other European countries. Sometimes that came a little bit later, but that process, in some instances, it's still going on. But nonetheless, the vast majority of those countries had attained their independence through these independence struggles, which you may have read about, Simón Bolívar and some of these other key characters, independence in Mexico, Argentina, and so on. And so with that independence came a desire among these actors, and this goes into the first kind of categories of actors I was talking about, to form a new nation and to build a robust populace, to build an infrastructure, to engage in really what was a watchword of the 19th century, which was progress. So modernity and progress. And to achieve that involved in some way, shape, or form engaging health and engaging medicine. So what you see in the starting in the 1850s, now at that time period, that was before the emergence of these theories of bacteriology and germ theory, which you probably are all aware of and have read about. So in the mid 19th century, much of the understanding of disease was still focused on environmental conditions or this idea of miasmas. So miasma means kind of like bad air, or we would call it polluted air, that would be more likely to cause disease rather than a pathogen. However, in that, even in that context where pathogens had not yet really been identified and germ theory had not become the dominant framework, which took several decades in any case, there was a real focus on sanitation in Latin America. So this era of modernity and progress, it can be one of the key aspects of that were kind of sanitarian efforts. And what do I mean by that? That means things like creating, to the extent possible, clean water supplies, building infrastructure with drains and other things, setting up more hospital systems that often were under the purview of the state, and eventually creating public health departments that would be both on the local level and on the national level. And so you see this playing out across Latin America from the starting in about the mid 19th century as part of this kind of building of nationalism and independence, and informed by what were the scientific theories of the day and general understandings of sanitation and hygiene. That shifts and expands to kind of what we would consider today to be our more modern, more, kind of even contemporary understanding with the advent of bacteriology and germ theory. And I don't have time today to go into that whole back history of some of the scientists who, discovered some of like anthrax and tuberculosis and some of these early pathogens that were determined to be to cause specific diseases. And these were specific, bacteria, viruses were discovered later, but pathogens, and this understanding that it wasn't miasma, it was specific infectious agents that could cause disease that typically were communicable and they were transmissible. Sometimes they were transmissible from person to person. Sometimes they were transmitted in water supplies or in food. Other times they were transmitted, and this is a very big part of understanding the history of health and public health in Latin America, through mosquitoes. So yellow fever, malaria, and other types of parasitical diseases. So the starting around the 1880s and 1890s into the early 20th century was really a great boom of the rise of bacteriology and germ theory in Latin America, which shaped public health departments and also shaped how they approached thinking about health in general and particularly public health. And this is where, even though these countries had become independent and they were their own nations, they often were in very close contact with European scientists and European ideas of disease, and particularly with respect to thinking about like Louis Pasteur and the germ theory of disease. Now, that doesn't mean it was like unidirectional. It wasn't just like Latin America accepted ideas from Europe. They also transmitted their ideas back to Europe, and there were international networks that exchanged these ideas. And some of those networks, I think Stephen Palmer might talk about in his talk later today. But nonetheless, one of the things that I've always found interesting in this history is that the Latin American scientists were very quick on the uptake of bacteriology and these new scientific theories, and responded to them quickly. And they were quicker on the uptake than the many of the US scientists were, where there was more hesitation to actually accept this idea that a pathogen, something that you couldn't even see, could cause a disease that could be devastating and lead to death. So I've studied in my research Mexico, and Mexico was very much at the forefront of developing its public health around these, what were at the time novel theories of disease in the late 19th century. So that then, of course, then meshes with what I had mentioned before in terms of hygiene and sanitation, so that you begin to see by the 19 early by the early 20th century, really plans, the ability to and implementation of creating systems of potable and clean water, definitely pasteurization of milk and other substances, and a real focus on building this kind of sanitation with an awareness of bacteriology, et cetera, into urban planning and communities. There also were, some of you may have seen, were to go back to any newspaper in the 1920s or 30s, in the US or in Latin America, you would often find ads or kind of public service announcements on the importance of not only public hygiene, but private hygiene. And what they mean by that is this idea that people should be washing their hands, they should not be spitting, they should be using a handkerchief if needed. Regular bathing was generally, began to be seen as a good thing, and so on. So that is kind of a general backdrop. At the same time that all of that is happening, you do have the emergence of dedicated public health departments, and also, medical, the medical field, and clinical sites that are focused on disease prevention. And much of the early work is focused on diseases that were understood to be infectious diseases. So a lot of the early work in public health is on infection control and on prevention through vaccination. Was also focus on sexually transmitted diseases. It's later, and this is a pattern you see in the US and other parts of the world as well, that the focus is, particularly after World War II, becomes focused more and more on chronic diseases such as cancer, diabetes, immune disorders, and obesity, and so on. So these are some images that I culled during my research over the years to show you what this actually looked like on the ground. So thinking again about these actors that I talked about. So in Mexico, as well as in other parts of Latin America, the public health units would go out into communities, often rural or semi-rural communities, and would bring information and treatments and tests to populations. And they would do their very best to get community buy-in. And so this would be an example of this from the 1920s, when all of those various elements that we talked about before, such as the focus on hygiene, the focus on sanitation, the focus on bacteriology. Here it's looking at tuberculosis is in place. This is from 2 decades later, but here you have a very professional looking ensemble of health professionals. These were visiting nurses that played an integral role in the rollout of both public health and medical care in general in Latin America. And they were often, the nurses would often be the link between the public health department and or the hospital and the actual household or community. And they would do a lot of the translating work in terms of actual understanding a medical situation or particular ailment, or a community situation. These are just some more images from the 1920s. The point is to show you that this infrastructure was being built up. It existed by the early 20th century, and was, had each country had its own national kind of character when it came to what their public health system looked like. An element of this that I've done research into, which was mentioned earlier, is focusing on the history of eugenics in Latin America. So, what was eugenics? Eugenics was this idea of better breeding or human improvement. And it's really interesting to look at how it played out in Latin America. When we look at the history of eugenics, when most people associate it with Nazi Germany, which is totally appropriate because in Nazi Germany, eugenics took off to, in an absolutely horrendous way and informed racial hygiene and sterilization and ultimately euthanasia with very strict understandings that bad genes must be eradicated, you know, in the worst case scenario through, genocide of peoples. In Latin America, eugenics actually existed, but took on a pretty different character. Um, One of the reasons why it was different in Latin America was that in Latin America, many of the public health thinkers rejected these really strict ideas that were popular in Germany and in the US, where it was like a gene must be eradicated, through sterilization, or this gene is associated with a population that must be eradicated. Instead, the focus was on this idea that populations can be improved and even the genetic makeup of a group could be improved through environmental changes. Now, that doesn't mean that these policies weren't heavy handed, and it doesn't mean they didn't target particular groups and have biases and could be discriminatory, but it means that they played out in different ways. So in my research, I've explored the rise and the character of eugenics organizations throughout Latin America from the 19 teens to really the 1950s. And one of the things that's important to note is that the emergence of public health in Latin America often had a pretty strong eugenic flavor to it, which was this idea that to improve social hygiene required a range of interventions that would cure, quote unquote, like racial poisons and would lead to improvement and betterment. And you can see this in the 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 both the terminology that was used and the kind of medical expertise that developed. So you can see it in the context of social hygiene. You can definitely see it in the rise of anything related to reproduction and childcare. So Latin America became one of the kind of hotbeds for something called puericultura, which was really this broader idea of pediatrics and of kind of improved and healthy child rearing, which had a lot of eugenic overtones about creating the healthiest and the halest children through a series of health interventions. You also see it in mental hygiene and criminology and so on. And, in what historians we often do, and I will put things in a timeline, try to understand how they evolved over time. But this gives you a sense of the reach of these eugenic organizations in Latin America, starting with the first one that was founded in 1913 and actually was based in Cuba, and then unfolded in Argentina and Mexico and Peru and other parts. And here are some of the conferences that took place. And you note that not only were there international conferences in Europe and the United States, but that there were Pan-American congresses on eugenics and homiculture. Homiculture basically means the improvement of man, through a variety through public health interventions, which had a whole range of biases related to immigration and ideas about reproduction. I'd be happy to talk more about those later. I think that maybe Tori, Dr. Langland in her talk might touch a little bit on puericultura in Brazil, where it did play a role in, childcare and things like the creation of milk banks and so on. But it's just important to note that this was this kind of environmentally oriented eugenics was an element of the emergence of public health in Latin America, and we can really see it in certain social dimensions, especially around children and child rearing. And here is an example of, in fact, of some images that, again, I've gathered over the years of one of these, again, going into the community. And it's really kind of this double-edged sword where on the one hand, if I look at this critically, I can say, wow, this was really infused with ideas of what progress was, what civilization was, what norms mothers should be following that were middle class norms that were coming down from on high. We can criticize them for being top down. At the same time, often these were, well-intentioned efforts to go out into the community and to reach people with health improvements. That kind of double-edged sword is something that continues to play out to this day, and in fact can often determine whether an intervention is going to be more or less successful or have uptake from the local community. And here are some more images. It gives you a flavor of what this actually looked like, these kinds of interactions between a visiting nurse, a physician, a family member, a child who is being evaluated and maybe getting treatment and so on. Another aspect of this eugenics that I mentioned were prenuptial certificates, and these existed in a few countries, including in Argentina, where where actually policies were passed that required that before individuals could marry, they had to be tested for venereal diseases such as syphilis and so on. And if you see in this image in the back that if they there was this fear that, people, were marrying and were going to reproduce with STDs, which were often seen as having some genetic component. And that would not only bring kind of death to them, but it would bring kind of, decay to the society at large. Okay, so shifting gears a little bit, one of the, kind of in again, in broad general terms, one of the things that we see over the course of especially as we move into the early 20th century, 1900s, and we have, governments continuing to develop with their ideas of nationalism. They are incorporating as critical to thinking about citizenship and kind of well-being and growth, ideas of health and hygiene. And so it's important to always stress that, in understandings of what a citizen would be and what the populace would look like, ideas of health were often paramount and they were integrated into critical documents. So, for example, and some of you may know that there was a revolution in Mexico in 1910, which, one of the things that came out of it was their Constitution of 1917, which was a kind of a rejection of the earlier ideas of modernity and progress, and meant to be a more kind of progressive, inclusive document for all Mexicans. This document included, it's pretty early, clauses that the state should guarantee health to its citizens. This, many decades later, was included in the Brazilian Constitution in 1988. It's been included in across the 20th century, other Latin American states in their constitutions and other social compacts have really included this idea that health is integral to the well-being of the country and should be provided in some way, shape, or form to its citizens. That there's a lot to unpack there about that, what that actually means, and if that was a promise or an ideal that ever could really be met, given a whole variety of constraints and challenges. If we look in more broadly at kind of health indicators in Latin America over time, we do see that they have, increased in terms of life expectancy and infant mortality, broadly speaking, across time on average. However, like anything, if you look at something in the big aggregate, once you start delving down into the details, you're going to find that there's a lot of differences. And so there are vast differences from country to country in terms of how this has played out. It often relates to issues of class, to race, to gender, and geography. So this is where, if we want to understand what health actually looks like for individuals or groups, we would apply this idea from public health, which is one of social determinants of health. That health is often determined or can be determined by a panoply of different social factors that relates to one's socioeconomic status, one's race. In the US, we often say health is directly correlated with zip code. So think of applying that concept to Latin America across this vast region. And then, of course, what we see in Latin America and other parts of the world is that, even once there's some stability or, some improvements in health, those can be really challenged or challenged you know, um, and challenged and pushed back by health crises, such as HIV/AIDS, pandemic influenza, Zika, and now COVID. Okay, so here are some charts that really kind of capture change over time in terms of basic health indicators in a good number of Latin American countries. I am not going to go through these one by one because that would be super boring. This is meant to be for you to be a resource to look at, something that you might want to use in teaching when looking at some of these differences. So for example, you might have students pick 3 or 4 different countries, and these indicators, looking at them, would be helpful in understanding some of these differences and social determinants of health. And what here you would see the interconnection between something like the GDP of a country, the level of poverty, the level of literacy, and how that then is correlated with life expectancy. I like to share this slide because it shows that, even though, it shows, first of all, that life expectancy has risen over time, gradually, across all these different Latin American countries. Even if those have been, a year or half a year or whatever. It also shows, however, that there are dramatic differences among the countries. So if we look at, this takes us up to 2010, the country with the highest life expectancy here is Chile, which is one of the wealthiest of the South American countries. There's a whole back history there around the role of health and the government that we can't get into here, but you would begin to see how some of the factors that would contribute to that are the social factors. And then here we have the lowest, which is Bolivia, which is a country that has fewer resources, has a much lower GDP, has a greater presence of indigenous populations, and so on and so forth. So here we go. Again, I'm not going to go through all of these, but I think as we begin to unpack this, you can see how these differences play out in ways that frankly will not be very surprising, because the kinds of correlations between GDP or literacy, life expectancy, maternal mortality, and so on and so forth are ones that we can understand. So if you go, well, let's go back here for a minute to evolution of life expectancy. So one of the reasons why life expectancy, and these are the South American countries, by the way, increased is because many Latin American countries made strides in containing the infectious diseases that had killed so many in the late 19th and the first half of the 20th century. And this is a trend we see across the globe. So the scourges of influenza and of cholera, although it had bouts here and there, but infectious diseases that killed large numbers of, were the highest kind of killers, so to speak, in the early 20th century, over time shifted and morphed to become, not in all countries, but in most of countries, to become chronic diseases. So there was a replacement of these infectious diseases with chronic diseases as some of the main causes of mortality. And that helps to explain, that is both in itself a reflection of, and one of the reasons why we see a rise in chronic diseases, because if people are living longer, they have more opportunity to have chronic diseases. And so we've seen, this is a poster from Peru, which talks about some of the basic statistics of what cancer looks like in Peru, what some of the different types of cancer are in men and women, and so on and so forth. And one of the things that we've seen is in Latin America and other parts of the world, that as people have gotten older and they've had these demographic transitions, there's more and more chronic diseases that include cancer, diabetes, cardiovascular diseases, and so on. And here's a graph that shows us that. So if you look at this, it is very striking to look at this from a global health perspective, because one of the things that we see is that the wealthiest parts of the world, looking particularly at, let's say, Europe, chronic diseases, have a much higher presence, for example, than in sub-Saharan Africa, where both cases and mortality related to, caused by communicable, maternal, perinatal, and nutritional conditions far outnumber. So if we look at Latin America, we can see that Latin America is pretty much on par with the Middle East and North Africa. And we do see that chronic diseases have overtaken infectious diseases. These are more stats that you can look at a later time, but I hope they will be useful to you. This shows some of the interventions. This is a really interesting chart, and these charts are often really helpful in understanding, well, what do public health interventions actually do? Like, how do they improve things such as infant mortality or these other indicators? And, this one shows that, starting after 1980, these various campaigns and programs were implemented in Mexico with the purpose of having a positive impact on infant mortality rates. And in fact, over in the aggregate, again, on average, they had done so. So vaccination, clean water programs, so on and so forth. So again, more slides. These are trends in cancer-related mortality. All of this speaks to what I have talked about in terms of interventions around infectious diseases and public health, the rise of chronic conditions. So I'm going to wrap this up with a few final points. So in thinking about Latin America in terms of health and global health, going back to this broad time frame, really, in fact, thinking about the 20th century is one where we've seen the development of public health infrastructures at the local and national level. We have seen that those are very often connected to international efforts, and that regions are different and they vary based on their histories, and those histories of both their previous histories of who colonized them, what are those back histories, as well as what are their their specific political histories that have played out over time. Latin America itself was, obviously key to the birth of the Pan American Health Organization, which became part of, so that was formed in 1902, called the Pan American Sanitary Bureau. The US was very involved, both in ways that were imperial and in ways that sometimes could be more collaborative. After 1948 and the creation of the World Health Organization, PAHO is its acronym, became one of the regional kind of satellites of WHO, although it retained some more, I would say, more independence than many of them because it had this earlier precursor history. This one, I bet Steve will have something maybe to say about this. I think he may have even given me this slide, which is about the role of the Rockefeller Foundation as an international actor in public health in Latin America. So the Rockefeller Foundation played a key role in many of these efforts in public health interventions that we talked about, with the similar effect of being quite imperial, even colonizing, at the same time having actors that would go into communities and sometimes be very much shaped by those communities in terms of what they were trying to do. I will go through some of these slides quickly because I know I'm running out of time. I think you read in the article, with our recent, President Trump has pulled out of WHO as well as PAHO, which has impacted the ability of it to respond to COVID in Latin America. For a long time, the US was very invested in PAHO and in inter American health. Another key, really interesting aspect of understanding health in its international dimensions in Latin America is the role of Cuban medical internationalism. And I realized I didn't finish a sentence there, but the point is that after the revolution in 1959, I talked about how for many countries that were finding independence or building up their nationalism, health was a crucial part of that. And that was very much the case in Cuba, where health and medicine became one of the hallmarks of understanding Cuba under Castro and Cuba, to this day. And the year after the revolution, Cuba sent a mission. Its medical professionals were sent to Chile following an earthquake, and that kind of set was one that initiated this internationalism, which has played out, and grown over the past decade. So as we speak, the Cuban doctors are in about 70 countries, over 70 countries, and more than 30,000 of them are across the globe. Okay, I'm going to pass through this because I want to leave time for some questions. This is all about medical, the international aspects of health and public health. So let's wrap this up with a discussion of epidemics and infectious diseases. So I think I'm actually going to start with this slide. So one of the things that one of the ways in which we can understand the kind of how public health is doing in Latin America, and also understand kind of the impact of these international arrangements, is by looking at what happens when epidemics and infectious diseases appear. And there are numerous examples of that. Some of those are very localized, like when there were cholera outbreaks in Peru in the 1990s. But certainly most of you remember when H1N1, which was this, variant of influenza, emerged in 2009 and hit Latin America really hard. And you have to remember that they're in the Southern Hemisphere in Argentina, where they, immediately faced in what would be, basically our summer, their winter, was one of the hardest hit countries. And some of the research that I've done previously looked at pandemic influenza and responses in both Mexico and Argentina. And what we learned from doing that research is that, the way countries responded, not surprisingly, often had to do with how their public health systems were organized. In Mexico, their response was more kind of nationalized and more top down, which rubbed some the wrong way, but was more effective in terms of mitigation strategies. In Argentina, there was no coordinated national response to H1N1, and it was left to, really the provinces and the cities to respond, based on their own kind of ingenuity and devices. In this paper that we published on Argentina's response, we look at two provinces and one city that responded with, really good mitigation measures, which are akin to what we're doing with COVID. It's about social distancing, about not shaking hands, about not so social distancing, not shaking hands, wearing masks, and so on. Now, with the emergence of COVID, Latin America has been hit really hard by COVID. Over 1/3 of the world's deaths have occurred in Latin America. Even though Latin America has 8% of the global population, it contains 30% of the cases of fatalities. And you read in the article about the absence of PAHO and Pan American health officers, which is something that has developed in recent years, and also the role of both Bolsonaro and Trump in the dismissal of Cuban health professionals, which has played a role in that. Okay, I'm going to wrap up. I always have a lot more to say, but I want to stop there and offer some reflections and then take questions. So what we've seen is that Latin America has been invested in health and public health and developing medical systems, coming up with ways of guaranteeing health and providing in health insurance, if possible, in general. And this is Cueto and Marcus Cueto and Steve Palmer, who you'll hear from later, have coined this term health in adversity to describe Latin America more generally, where Latin America in challenging situations nonetheless has managed to build fairly robust and sophisticated public health systems, even though those are uneven from country to country and are really shaped by these social determinants of health from place to place. That is evident in who has access and who has coverage, who has what the ratio is of doctor to to doctor to people in particular countries, and so on. One of the things that is striking about Latin America, though, is in this country, in the US, there's still ongoing debates. Some people believe health is a human right, and others certainly do not, and see health more as a commodity or something that is much more, commercialized, or people should not have, basic access to. Really across the board in Latin America, except with a few exceptions during particular governments and so on, that it really has been accepted across the board that health is a human right. That resonates with the WHO and the United Nations and a more internationalized understanding of health. And then finally, there obviously COVID is having an impact. Infectious diseases, I didn't even talk about Zika, which I've written about, had an impact and is still playing out in Latin America, particularly in Brazil and Colombia. But rising chronic diseases are key to understanding health in Latin America in 2020. And as is a topic that I wish I knew more about, some of my colleagues do, which is the continued role of indigenous and kind of native health practices that they play in shaping approaches to health and well-being. Okay, with that, I will stop and I will take questions. Let me stop the share. Here we go. Okay, thank you.
Thank you, Alex. That was great. This was very informative. I think we've all learned a lot. I've collected some questions. First, I just wanted to pick up on something that you were just ending with. How does the current COVID-19 crisis compare or contrast to other public health emergencies in Latin America, such as the Zika virus in 2016, but as you said, ongoing?
Yeah. Well, I think that, the enormity of COVID has engulfed every part of the world. And, Zika was really, one of these startling emergencies when it happened. And it still is very much a concern, although cases have really diminished substantially. The way that Zika continues to play out is in terms of, the children that were born with microcephaly and other health conditions, and questions about their ongoing treatment, and, really living with those developmental disabilities. I think that Zika shows us a whole range of things related to Latin America, which could be related to thinking about reproductive rights and access to abortion, but it really shows strikingly the role of poverty and social determinants of health in terms of who was most affected by Zika, the moms that were most affected in, for example, northeastern Brazil and so on. So Zika certainly is still requires study, and was a significant epidemic outbreak caused by a mosquito, as we know, and there's likely more of those to come. I mean, we know that mosquitoes are vectors of a wide range of diseases that we have in Michigan with, encephalitis and so on and so forth. In any case, I think that COVID, again, is so massive, and you know, how do you know, with mosquitoes, there are ways of controlling mosquitoes through often controlling water supplies. There were really bad ways of controlling mosquitoes in the 20th century, like DDT, but there are other ways of basically controlling mosquito populations so that with enough resources can be effective to some degree. However, with COVID, I mean, I think that there are a few reasons why COVID has hit Latin America so hard, and I would love to hear from others if what they think about some of these hypotheses. The first is um, the unevenness of access to medical care, and the way in which, again, we see in this country, COVID is a disease that is disproportionately affecting people of color and people with chronic underlying conditions that are connected to social determinants of health. That is playing out in similar ways in Latin America. There are also questions of density, where social distancing is a privilege that many of us can practice. It's not a privilege in this parts of this country and many other parts of the world, including highly dense areas. If you think in Latin America, particularly in Brazil, and also people tend to live more in intergenerational households, where you are, that contact, which is a beautiful thing in many ways. However, it's not great when it comes to COVID. And of course, I think that in some of the, wealthier private hospitals in Latin America, there's access to things like antibody testing or antibody remdesivir or some of these other treatments, which may or may not work. There's some like serum, treatments that work apparently, but there's really not access to those as well. So I think that it will be interesting to see what happens with the different channels and distribution of COVID vaccine, now that it looks like at least one is, there's one, the Pfizer one, there's another one that was developed by Russia, which we've heard less about, how those are going to make their way into Latin America. But I think COVID is just so massive. I mean, it's changed everything on a global scale, that even H1N1, which was so dramatic when it happened, there also was a treatment for that. There's Tamiflu, there's a kind of a retroviral that if you take within a certain amount of time, of course you have to have resources to be able to take it and so on and so forth. But yeah, I think it's just really hard. And we see cases increasing all over. Argentina has gone back into a shutdown. We saw what happened in Ecuador, Brazil. It's been tragic. It's just very depressing. I mean, that's the only way I can really explain it. Yeah.
Well, yeah, thank you for that. I mean, that's a difficult topic. I would just have maybe time for one more quick question. This is kind of a broad, overarching one that I thought I would throw out to you. Most of the people attending this or watching this video are either high school or community college teachers and instructors, right? So what do you think high school students or community college students in the United States should take away from studying public health issues in Latin America?
Well, I think it's, there's always the virtue of the comparative aspect. So understanding, our particular predicament in the United States, of why, we're a wealthy industrialized country with the resources to provide much more comprehensive care and access to health to people. Nonetheless, it hasn't really happened, and we're suffering right now in so many ways with COVID. Compare that to Latin America, or at least some of the ideals of what I've talked about in terms of health being written into the Constitution. The other thing is, I think that for students, again, going back to a point I made at the beginning, one of the fascinating things about studying Latin America is just how diverse it is in terms of the histories of each country, in terms of the languages that are spoken across Latin America, including indigenous languages, in terms of the culture, you get into the culture, the food, the music, all of that. And so I would say that Latin America is really a region where you can pique students' interest for understanding broadly, a place where, the vast majority do speak Spanish, where a language that's relatively accessible for a lot of them in high school can then translate into understanding, these different cultures, to the south of us. So that would be one thing. And then I think in terms of health, I just think it's really interesting to, to ask them, to maybe do a project on like, there's a lot of like still negativity around like Cuba and socialism and Fidel Castro, but okay, we'll take a look at their medical internationalism. Like that program really works. I mean, that's a, beacon for the world. So maybe take off some of those, it's a way to challenge some of the framing that we has been handed down to us as Americans. Certainly it has problems. I'm not going to kind of idealize it as the holy grail, but still I think that could be good too. So breaking stereotypes, looking at other examples, learning from them, and again recognizing, the real diversity and heterogeneity that makes up Latin America, which is then reflected in its health patterns and its approaches to health and public health.
Great. Thank you, Alex. Dr. Victoria Langland holds a joint position in history and Romance languages and literatures at the University of Michigan and is currently serving as the director of the Center for Latin American and Caribbean Studies and the Brazil Initiative at U of M. She specializes in 20th century Latin American history, especially Brazil and the Southern Cone, and writes about gender, dictatorship, uses of memory, student and other social movements, and more generally, the intersections of culture and power. She is the author of Speaking of Flowers, Student Movements, and the Making and Remembering of 1968 in Military Brazil, and the co-editor of The Brazil Reader. Langland's current research project is a history of breastfeeding in Brazil that looks at how cultural understandings, public policies, formula marketing, and other factors have transformed popular beliefs and practices about infant nutrition in women's bodies over time. And she will be speaking to us today in a talk called Got Milk, Histories of Human Milk Banking, Race, and Motherhood in Brazil. So, Dr. Victoria Langland.
Well, thank you so much, Tim, for the introduction. And thanks to everybody for coming out on a Thursday night. I know that if you are like me, you spent most of the day on Zoom, and so you are well acquainted with Zoom fatigue. So it's wonderful that you were able to come in for one more thing. And I presume too that seeing my children go through Zoom education, their teachers are so magnificent at what they're doing. They're so much better than I am that I'm guessing that you're all just going like, we're better at this than you guys. What I've seen from my elementary school teachers is just remarkable Zoom skills, much better than mine. So I will do my best. So I wanted to just say that, first of all, as Tim already said, I am working on this project on the history of breastfeeding in Brazil. So this is ongoing research. And I was trying to think about ways that might be useful for you in the various kinds of classrooms that you're teaching in. And Tim told me that most of you are either from high school or community college. So I'm imagining that the age groups that you're working with are not that dissimilar from the age groups that I'm working with. So it's not, we're really thinking about sort of young people nearing adulthood or in young adulthood. And so it gave me a chance to think about, when academics write, we always think about writing for other academics, which is really boring. But when I thought about, what would I want young people to know based on this research? And what did I think young people should know about race and public health? I sort of started with a couple of premises that I just thought I would begin there. That one thing is, I think that anytime we learn something about another place, it helps us understand at least two things. In other words, I know I'm not talking about a place that most of our students are familiar with. Some might be, but I don't assume that people know much about Brazil. But it lets us think about at least two things that might seem contradictory, but that I think work together in really useful ways, right? So first, simply, learning about a place like Brazil lets us understand how diverse the world is, right? How many other experiences and understandings and ideas and practices there are around the world, and really across the past as well, thinking about the concept that the past is also a foreign country. And so I think that the immensity of human experience is really beautiful. And I know that with my own students, I openly want them to get a taste of what that is, like that one of the pleasures of being a human, right? Of being a sentient being is to consider the vastness of our human experiences so that they'll hopefully spend their lives curious about the rest of the world, in the present and in the past. So that's like, why study milk banking in Brazil? Well, one answer is that just learning about Brazil is an important part of developing curiosity about the human experience. And on a related note, I want them to use these kind of intellectual trips to foreign places and times as opportunities to really practice and deepen their skills of empathy. That is the ability to understand another person's perspective, even if that perspective would otherwise be, foreign to them. And I believe that empathy is a skill that we all need to practice. It's not something we're just born with and we either have it or we don't. And so I feel like having them really think about the other, in this case, Brazil, something that's not as familiar to them, brings them a sense of the ability to practice empathy. So that's one of my notes. But then the second thing that's kind of contradictory is that I think whenever we learn about, quote unquote, the foreign or the other or something that's distant from us, it actually makes us understand our own societies better and hopefully to think critically about them. And you're probably familiar with like a common experience for people who travel outside the United States, either for the first time or even multiple times, who say it's only when they left their country that they'd be able to really start to understand it, right? People say like, oh, I really only started to, figure out what the United States was all about when I went abroad to whatever place it is. And I looked back, and hopefully not in the genre of like, I learned that everything we do here is correct and everything, whatever people do somewhere else is wrong, but more in the genre of like, why do we do things this way in the United States? I just went to this other place and they do it differently. And what's that about? Where did this come from? So for me, those are kind of the two premises that I start with when I think like, why would I want young people to even think about Brazilian history? With some of those things. And then I think that looking at Brazil is especially appealing because I think the US and Brazil have very similar histories and very similar ethnic compositions, but we've ended up with very different meanings of race. And I'll just put up a slide of a map of the two, of Brazil and the United States, that somebody helpfully put on the internet, essentially to show size, because Brazil is larger in geography than the continental United States. So people often like to kind of place these two together. But I'll point out some of the similarities that may be of interest to your students, right? That both began as colonies of European states, right? Of Great Britain and Portugal. In both countries, there was a conquest of vast territory that involved widespread violence against indigenous populations. In both countries, millions of enslaved Africans were brought against their will to live and toil. In both countries, these slaves and their descendants were only freed in the last half of the 19th century. Since abolition, both countries have received waves of immigrants from all over the world, ultimately forming pluri-ethnic societies. And in both places, light-skinned peoples have come to dominate their darker-skinned compatriots through racially discriminatory practices, creating what sociologists call racially stratified societies. And both places have correspondingly experienced long histories of anti-racist organizing and various efforts to address this discrimination, including measures like affirmative action policies. So I would think that students would find a lot to reflect on about Brazil that also makes them think about the United States. And now, despite these similarities, the resulting understandings of race are really different. In the US, race mostly refers to ancestry, while in Brazil, it has mostly referred to skin color or appearance. Thus, in the United States, the majority of people with any African origin are categorized as Black, many of whom also self-identify that way. I'm talking about sort of the way society categorizes someone as not always being the same way somebody self-identifies. And in Brazil, large numbers of people who are classified and who self-identify as white have African ancestors, while many people classify themselves as something other than white or Black, right? As mestizo, mulatto, moreno, pardo, and so forth, names that don't translate quite so easily into what we would say mixed race in the United States, which often still implies the child of two more singularly raced parents, right? Mulatto could mean, a history of racial mixing that is much easier to encapsulate in one term in Brazil than in the United States. So looking at Brazil helps students certainly to think about the constructedness of race, how it is that it is societies, right, and not nature, obviously, who create these categories of supposed human difference and assign them various labels and meanings. But it also helps them think about how ideas about race intersect with other socially constructed ideas like gender. So all of that is like parts of the ways that I thought, what are the, the big lessons that I would like students to think about when they look at Brazil, are some of these. And so I have two kind of driving questions about my research, more specifically, that I tried to encapsulate to explain what students might learn by looking at histories of breastfeeding and human milk banking in Brazil. And one is about how do public health initiatives reflect histories of slavery and racism? I almost put unwittingly in here, unwittingly reflect, because it's not always clear if this is, what the kind of agency is in that, but I decided not to. And then how do public health initiatives attempt to overcome histories of slavery and racism? And then if we get kind of down into the granular level, more specifically at some of the supporting questions, or what can a focus on breastfeeding tell us about society's expectations for different women in society? In other words, how can we learn more about society's unspoken assumptions and expectations? And how can we learn about the intersections of race, gender, and health by looking at them in the context of Brazil, right? And as I mentioned before, another country in the Americas with a similar kind of history of slavery. So to get into this topic then, if I were teaching this to students, and I thought about this too, like how would I teach this to students? I would probably ask them to first just think about breastfeeding, right? And maybe have them think about this topic that is so fundamental to human life, for all of human existence. And yet it's something that we rarely talk about, frankly, although that is starting to change in our 21st century society. So I would, think of some questions like this to ask students to, bring up this topic. What have they heard about breastfeeding? Is it good for babies? When have you seen someone breastfeeding? What did you notice about these moments? Maybe thinking about whether or not it was in their family or outside their family, how rare it might be to see someone not in your family, either immediate or extended, participating in something that's as simple as feeding a baby from the breast. How breastfeeding is represented in our society, have them kind of think about that. And then in discussion, I'd ask them to notice how we're often told that breastfeeding is in fact really good for baby's health. It's not the only kind of food that can nurture a baby. This doesn't need to become a debate about breastfeeding versus bottle feeding, but hopefully one where we can understand that breastfeeding is generally understood as a very healthy way to feed a child. But then when we talk about it as a society, what does it say about us and what we believe? Do we as a society think it's a private matter or a public matter? Do we think breastfeeding was any different in the past than it was today? When we start to really examine our ideas about breastfeeding and the women who breastfeed, what do we learn about ourselves? And I would then tell them, we're now going to look at Brazil, where they're known for having developed a really extraordinary system to support breastfeeding that is built around human milk banks. And here I would point out that Brazil is known among maternal and infant health experts as a place that has developed this really highly successful system of national human milk banks. There's an image here of the image on the left is of a person who works at a milk bank who's showing the collected milk to then the person who was then the Minister of Health at the time. This was from 2012. And funny, my Zoom is covering up some of the pictures, so I'm going to have to actually move there we go. There are pictures here on the top right of breastfeeding classes that were being offered to pregnant women. In the middle, there's a little preterm baby being fed breast milk out of a cup. The woman on the right is at a public event, bringing public awareness, doing public outreach about breastfeeding with this like funny little apron that she wears with breasts, fake breasts on the outside, and a plastic baby doll wearing a funny clown kind of wig to catch people's attention and go around in a joyful way and talk about the importance of breastfeeding. That all of these things are initiated through the human milk bank. And so in Brazil, there's a system of human milk banks, about 200 across the country, that collect donated human milk. They pasteurize it and they supply it free of charge to infants who need it, generally hospitalized, ill, or preterm infants. And Brazil has also helped other countries in the world, particularly in the global south, to create their own human milk banks and to kind of share this technology and what they've learned about this. And they've increased the average length of time that mothers breastfeed their children. In the mid-1970s, the average was about 2.5 months. And by 2006, this had grown to 14 months. So more than a year is the average amount of time that a woman breastfeeds in Brazil. And all of this has been great news for public health, right? There's better outcomes for infants and for mothers. There's less need for medical intervention as babies, medical intervention for babies, and better long-term health trajectories for children. And there's real connection between initiatives to support breastfeeding and initiatives to supply human milk banks with greater public health. So this is in many ways, a really exciting development. But the road here has not always been so smooth. And what's more, when we look at that history, it shows us how ideas about breastfeeding and human milk banking were long, and continue to be, I would say, tied up with ideas about race that emerged from slavery. So I want to then show you and think about how we would also show students what happened in Brazil and what that tells us about race and public health in Brazil. Uh-oh, why are you not forwarding? Hold on a second. Oh, I know, because I touched. There we go. Okay, sorry about that. So I would start at the beginning of the 20th century to say that this is a moment that actually Dr. Stern mentioned, in which states and non-state institutions started to become really invested in public health and in puericulture, among other things. And so physicians and public health officials in Brazil, like those in other places, repeatedly became very nervous about data that showed high infant mortality rates. This was a new kind of cause of concern for states who suddenly realized, or it became kind of common wisdom at that time, that producing healthy children was fundamental to national progress. So they realized that we really need to intervene. And this focus coincided with and was connected to the fact that pediatric medicine was increasingly becoming a professional field of medicine as well. So these two things happen at the same time, that the state becomes more interested in promoting public health, pediatric medicine becomes more professional, and you start to see more people concerned with infant health and what they might be able to do about it. So we see doctors, state officials, and others in Brazil who organized a host of social welfare organizations that focused on maternal and infant health, particularly among the poor. And so the picture in this slide is just one example for this, as that it says it's the Institute for Childhood Protection and Assistance in Rio de Janeiro. It was founded in 1901 by a doctor named Arthur Moncorvo Filho. He was a very well-known and influential pediatrician, the son of another well-known and influential physician in Rio. These are very elite circles who had the kind of, funds and connections, among others, to create an institution, and in fact, to build a building like this. This is a building they had built for them just some 20 years after they were founded. And this organization engaged in a whole host of activities. They provided free medical and dental care to poor children and pregnant women. They instructed mothers in what they considered sort of proper mothering techniques. They opened a dispensary where they passed out free clothing and food to children in need. Among other free food they passed out was free chocolate, which was seen as a healthy product to give children and help them grow, which my kids would love it if that were considered true today. And they also worked to improve infant nutrition by encouraging maternal breastfeeding. They thought that poor women were not breastfeeding as they should be. And this was not, just so you know, a breast versus formula controversy, because formulas, as we know them now, were not really an option for poor and working class women. Since the end of the 19th century, we saw in Brazil some imported condensed milk, which was sometimes fed to infants. And then we start to see similar products produced in Brazil soon after that, but they were not widely available to most families, and certainly not widely available to poor families. More common in the first half of the 20th century was for families to offer a variety of kind of paps that they made, like gruels, where they would mix together some kinds of animal milks, water, sugar, and flours made from different grains like rice, corn, or oatmeal. But animal milk, as Dr. Stern mentioned, especially in cities, was not always fresh or pasteurized, and water sources could be insecure as well. And so these paps could in fact be fatal. And so there was a lot of concern about high infant mortality because poor women were feeding paps to children in order to go to work or for other reasons. And these things were often contaminated and were causing high rates of death. So breastfeeding promotion became really central to what IPAI did. And just to give you a sense of kind of how important it was, I love this image. This was first a painting and then a stained glass that they had made kind of as their major symbol in front of the entranceway of the building, which shows a woman, breastfeeding a child. And when I discovered that it was a copy of this French painting, I really just found this fascinating, because in the original, she's not breastfeeding a child. That they had to change the painting So they're copying this like important image of charity, but they had to change it specifically to show her breastfeeding because that was so central to what they're doing. So as I said before, it's not the only thing that they do, but it's really kind of central to their mission of how do you support maternal and infant health, and how do you reduce infant mortality through this focus on breastfeeding. Now, among other activities, it also started hosting what they called robust baby contests, a useful way to promote what one portfolio here called natural feeding, where people would put their children, submit their children into these contests, and they would measure them in all kinds of ways and determine which child was the most robust. There'd be a big party. And the child would win some kinds of prizes. I actually have like lots of photographs of robust baby contests because I think they're completely adorable and also weird and fascinating. It's this kind of like scientific measurement of robustness, which they determine through a variety of different kinds of measurements. But these became really popular, and that's part of as well of why I have so many pictures of robust baby contest, which I unfortunately did not include all that I have in this slideshow today because that's too much. Although I'll point out that my favorite picture is the one on the left right here, where a series of mothers are waiting for either for the results or for the contest to start. I'm not sure why. And they're all, seated in the room with their unfortunately completely naked children. And do you see the little puddles on the floor? Because obviously they have no diapers on. So there's like little puddles of pee in the floor, which just, I find endearing. So, but to move on, it wasn't just the IPAI and organizations like IPAI that started to promote breastfeeding in the early 20th century. We can also see this in the messages of parenting guidebooks like these. And these really, I call them parenting guidebooks, but they're all directed specifically to mothers. This book is even called The Book for the Little Mothers, in which if you look at the chapters, maternal breastfeeding is critically important. If you see chapter 3 is maternal breastfeeding. I'm going to skip over chapter 4 for now. Chapter 5 is what they called mixed feeding, which was when you alternate maternal breastfeeding with some kinds of artificial feeding. Chapter 6, only near the end, is artificial feeding. If you read it, it's full of caveats about, only do this in the absolute, worst case scenario. And then chapter 7 is how do you prepare food under medical supervision to make it as, the least dangerous as possible. And it's not just in parenting guidebooks that we see this, but also even in medical guidebooks as well. Same kind of idea, in which, several chapters here about how to feed a healthy infant. The first choice is maternal breastfeeding, advantages and techniques, then obstacles to maternal breastfeeding. Again, this concept of mercenary feeding, which I'll return to, and then artificial feeding. So just looking at my notes. Okay, so mercenary feeding. I know you guys are mostly muted, but does anyone want to unmute for a minute and say what they think that might refer to? Are there any guesses?
Maybe it's like if they had another person breastfeed their baby for them.
Absolutely, that's exactly right. And what do we call that kind of person who breastfeeds for someone else?
Isn't it like, I don't know, this might be outdated, but I think I've heard the term wet nurse before.
That's exactly right. It's exactly right. And it's fascinating that you said outdated because it is a historical category. But as you're seeing, it's not outdated in 1950. And that's part of where I'm going to go with this talk. That in fact, they're referring to wet nursing, which has a long history in Brazil, which is deeply connected to the history of slavery. As enslaved women were forced to work as wet nurses for other people's children, either for the family that kept them enslaved, or sometimes for another family or an institution like an orphanage, in which the slave owner would rent them out for that purpose and then collect the money. And I'll just put up an image here of 20th century invocations of the history of enslaved wet nurses. This is just a tiny smattering of references in the 20th century that are visual. There are also lots of literary references, but sort of visual references to this figure of the enslaved wet nurse that suggests kind of how well recognized this figure is and the history that she represents. Now, the official word or expression for wet nurse in Portuguese is ama de leite, which we might directly translate as a milk nurse, which is also used as well as wet nurse. But during slavery, the kind of colloquial term, the kind of everyday term that people often use that became quite common, and that pointed to the many other kinds of roles that a wet nurse took on besides exclusively breastfeeding, all the kind of care work that she did, is Mãe Preta, which translates directly as Black Mother, which is why you see the term Mãe Preta in the slide. For the 1912 oil painting is called Mãe Preta, and the Mãe Preta monument in Sao Paulo from 1955. And that name is really suggestive, right? It speaks of the way in which understandings of breastfeeding were highly racialized and really deeply entrenched with ideas about power that come out of slavery. Because the term Black Mother shows how race, gender, and slavery were bound together in the very idea of a wet nurse, that's, she's envisioned as a Mãe Preta. And that's what this kind of corrupting image of what Black motherhood stands in for here as well. And what's more, it also points to ideas about white women. For the major justification for hiring wet nurses was the belief that breastfeeding was so taxing that it would injure white women who were too fragile to breastfeed. And in fact, some doctors in the 19th century counseled white women not to breastfeed, citing reasons such as weak nerves or maternal weakness. And some of their medical theses point to an understanding of breastfeeding as what they considered a great maternal sacrifice that kind of debilitated the body. And these same doctors, by contrast, presented Black women as being more physically suited to the labors of breastfeeding, especially in tropical climates. And it's kind of wrapped up in this vision that the tropical climate also weakened white women in particular. Now, by this point, students in your classes might recall that the US and Brazil have this in common as well, in that the US also in the US, enslaved women were forced to work as wet nurses. And so that may have already occurred to them, right? That we've seen this as well in the United States. So they may not have realized that wet nursing continued after abolition, both in the United States and in Brazil. Indeed, in Brazil, in the period leading up to and following abolition, which was in 1888, the last country in the Americas to have abolition. In that period, both before abolition, as people were debating it and seeing that this was coming, and there's actually a series of laws that gradually dismantled the slave system until it was finally fully abolished in 1888. During these debates, the figure of the wet nurse became a kind of primary way in which people talked about what the future was going to look like. As she, in many ways, became the scapegoat for so many of white slaveholding society's concerns. Doctors warned hiring families that she was a vector of contagion herself, that she could bring disease, that she could also bring, misplaced ideas and behaviors. She would bring superstition and immorality into hiring families' otherwise, pure homes. And we now see these critiques as reflections of the anxiety of white society, who began to openly fret that slavery maybe had corrupted their white society, who had become dependent on slaves in ways that they now saw as being at odds with their efforts to present Brazil as kind of civilized and modern on par with Europe. Many were also clearly influenced by ideas of Rousseau at this time about the importance of maternal breastfeeding as central to kind of the proper ordering of society, with domestic roles for women well fleshed out and women, taking on these roles. So we see this campaign against wet nursing, which was really more about the legacy of slavery and the direction of Brazil's future than it was about public health. That's at the turn of the century. So notwithstanding this flurry of debates, breastfeeding, sorry, I keep misspeaking, wet nursing continues in Brazil, and not just past abolition, but all the way through the 20th century. It diminishes, to be sure, but it continues, which is why, the commentator saying that sounds like an outdated term. That makes sense. Most people think that it dies off, and it does diminish in Brazil, but we still see it in the 20th century. So these are just some snippets of classified ads that I found in my own research of people placing ads in major newspapers. I think these are all from the Jornal do Brasil in Rio de Janeiro, what has been for a long time a major Brazilian national newspaper. In the classified ad sections, either looking to hire a wet nurse or looking to be hired as a wet nurse. And again, this is just a smattering, but you can see the ones that I've posted here date between 1940 and 1974. And I'll note too that this is not common knowledge. It's not well known. It's something that I'm, digging out during my research right now. So many people would be surprised by this as well. But this ties in with what we saw earlier, right? When we saw those parenting guidebooks that focus on mercenary breastfeeding, and they're published in the 1940s, 50s, and 60s. So this just goes along with other examples of the fact that wet nursing continues in this period. And in this period, many doctors did recommend it with precautions, but as a better option than what they called artificial feeding, even when formulas became more and more available. And again, we saw that when we looked at if we went back and looked at the chapters, right, that they all speak of sort of mercenary feeding as an option to take on before artificial feeding, right? If you can't do maternal breastfeeding, then you should have a wet nurse, because human milk is the best option for your baby. And if you can't do that, then how about some breastfeeding and some mixed feeding? And if you can't do that, then okay, artificial feeding is what you'll need to do. So these, it's still recommended medically, with some caveats. But here too, they carried over some of the same racialized ideas that we saw earlier. So when we look at those books and the sections about mercenary feeding, the language in those descriptions, and I don't have lots of quotes for you here, but the language in them is there's always a presumption that the hiring family is from a significantly higher social class than the wet nurse. So they're not specifically about race in these moments of the 40s, 50s, and 60s. They're not specifically saying that there's a racial difference, but it's so deeply coded in the class differences that it's quite clearly implied. And indeed, to the extent that there's a real concern about hiring wet nurses in this period, it's not at this point about disease so much as about the tensions in that class difference. So there's lots of sections in the chapters about how do you have someone who's trusted enough in your home, who's not going to set a bad example, who's going to follow your orders, who's going to eat the foods that you think that she should eat to make healthy milk for herself, which is really for your child. And also much concern about what to do about her own child, because in the slave owning past, that was seen. I think doctors had become cognizant of the fact that wet nurses' children were often sacrificed in the slave owning past for the charges that they breastfed. And in the 20th century, they tried to mediate that, but it was really up to the hiring family, who often would, only hire somebody if she didn't have a child with her. So there's a lot of tension in those texts. So it's in this context then, in the 20th century, that we start to see the rise of human milk banks. And I'll just put up a quote here of a figure named Marta Gangesteira, a doctor from Bahia, who really sees milk banks as the solution to what he saw as kind of the problem of the wet nurse, right? The problem of the wet nurse: hard to control her, hard to hire her, hard to secure her labor. So wet nursing, he says, is finally going to die out, but human milk banking is going to be this new solution. And what we see in the development of human milk banks is that when organizers start to think about who will supply the milk for the human milk banks, it's completely normal for them and quote unquote natural for them to turn to poor women of color. And so we see, for example, Gesteira set up the first human milk banks in Brazil in the 1930s in Bahia, that's a state in the northeastern part of Brazil, in which he connected the milk bank to a maternal shelter, a place where destitute women who were pregnant could go to recover after having had a child. It was right next to an orphanage. So the thought was that when they came to an orphanage, perhaps to turn over their child because they couldn't raise this child because they were so poor, they would be offered a chance to go into the shelter instead. Why don't you come and stay in the shelter for a few weeks? We'll feed you, we'll take care of you. You'll keep your child with you. You'll breastfeed your child for the time that you're there. You'll also donate milk through, this is a woman with a milk pump right here on the left-hand side. You'll also express milk for our milk bank, and we'll pay you for that milk so that when you ultimately leave 2, 3, 6 weeks from now, you'll get that money in a lump sum. And then the hope was that when she left, she would have a little nest egg that would make her want to take her child with her rather than leave her child at the orphanage. That was the thinking of the organizers. So on the left, there's a woman with a single breast pump. And then on the right, there's when they purchased a new Italian breast pump that seated, I can't remember, was it like 16 women? You'd have to count. It was like 12 or 16 women could all, pump milk at the exact same time. But this was this development by Gestera that he thought was magnificent. He said the residents of the shelter were the paid wet nurses of their own children, and that this was going to both benefit them and their children, and at the same time produce milk for the first human milk bank. That milk was then, it's a little unclear in the documentation, but it seems that milk was then sold to families who could pay for it, and also used in hospitals as well. And it leads to other human milk banks in other states. Here's an image of some of the residents at the shelter. But this early milk bank here in Bahia leads to the creation of other human milk banks in other cities across Brazil, often tied to maternities where poor women would give birth, or to hospitals. And so you can see this as, as a sign of real development. And in many ways it was, right? It brings access to human milk to children who needed it. But they also continue to recruit donors from the poor. They would go to public maternities and health clinics that treat the poor in order to find donors, and they offer them payment. However, they don't offer them a lot of money. There's always this concern, this mistrust of poor women, that if they offered them too much, that they would somehow abuse the system. They would starve their own children in order to make money. They would find ways to doctor the milk that they donate in order to make more money. There's always this real tone that you can't trust the women to pay them more, or they would, act out badly. And so I hope this isn't too small. This is a quote from the assistant to a director of a human milk bank in 1958, who said, so that there are no absurdities or exaggerations, here we've adopted the weighing method. The wet nurse is required to bring her child when she comes to the bank, and we weigh these children daily to see if they're being well fed. This is how we avoid having the mother stop properly breastfeeding their own child in order to earn more. And so it's just, for me, it's just infused with this assumption that wet nurses are not true mothers to their own children, that they, would easily sell them out in order to earn more money. And they create all these different ways and all these strategies to make sure that doesn't happen. Just see if there's something else I was going to say about that. And we also see in the language, I know what I was going to say. But one of the things that happens for the milk banks is that they're constantly running short on milk, that it's hard for them to find donors who would subject themselves to this kind of response, right? Of very low pay, obviously mistrust. And they come up with a lot of ways to ensure compliance among women. They say, for example, we had a hard time getting milk donors to come in on Sundays when we needed milk. So we decided to only pay them once a week and to make sure that the payment was on Sunday, so that people could only get paid at the end of the week if they came in and donated milk on Sunday as well. So that there's a lot of manipulative behavior that makes the milk banks often run into trouble in terms of getting donors. And we see among some of the milk bank organizers a real wish that they could have more maternal shelters attached to milk banks, because there they had a kind of captive population, and it was a lot easier to secure human milk donation at that point. Now, if what I've been trying to argue is that this is kind of infused in ideas of seeing poor Black women as the natural place to go to for human milk, we can really see that clearly in this statement from 1960. This is in a journal by one of the medical institutions that had a milk bank in Brazil, actually that still has a milk bank in Brazil, where they reflected back on 15 years of human milk donation. And he says here, the donors represent the third or fourth generation of good breastfeeders. The Mãe Preta, the Black mother, has always been revered, among other reasons, for being an efficient wet nurse, someone the Brazilian family counted on during the Empire, which was 1822 to 1889, and into the Republic, the period after 1889. In advertisements of slaves for sale, they always proclaimed lots of good milk, which they had. So the donors of the milk bank are in some ways continuing a tradition. Heredity would have some role in milk donation as it presents today. Its influence has been noted alongside other factors. And it's interesting to note that within the group of the best donors, many of them inform us that their mothers breastfed all their children, and they were many, during long periods, a year or more. So in statements like this, I feel like you can see them really drawing on this long history of race and slavery in the way that they imagine, who human milk donors should be and in how they should treat them. So I'm going to conclude with a few things to say that it's really only after the 1988 Constitution that human milk banks have to reconsider their practices. And I don't know to the extent to which they reconsider the racial assumptions behind those practices, but they are forced, in fact, to reconsider their practices, because what happens is that in 1988, and Dr. Stern mentioned this earlier, Brazil writes a new constitution in the wake of a military dictatorship. And because of other unrelated concerns about selling human organs on the international market, it is prohibited in the Constitution to sell any human substance. And so you can't sell blood, you can't sell human organs, and you can't sell human milk. So that it wasn't about human milk, but it ends up becoming that you cannot pay donors for human milk because it's prohibited in the federal Constitution. So the milk banks, who in fact had been struggling to get donors, suddenly have to come up with a new strategy. And they do. They come up with broad publicity campaigns. In fact, let me just see. Yeah, this is a much more contemporary image, but they come up with lots of publicity campaigns. They use celebrities in many cases. They have lots of kind of public awareness campaigns about the importance of breastfeeding, human milk, and human milk donation. They turn human milk banks into centers of infant and maternal health, a little bit like that first slide that I showed you, where they offer all kinds of classes, where they try to bring people in and see what it is that they're doing. They create very close ties with donors by having telephone calls to check in and how are you doing and how's your baby, having visits with them, including home visits. They create all kinds of workshops and they have celebrations for the donors and their children. So they really, they turn on this change and really make the human milk banks a much more community focused and kind of centers that do a lot of activities besides just collect and pasteurize milk. And that what they found is that the donors now come from all social classes, right? They donate for multiple reasons and they get to meet one another, and you get to have all kinds of, interaction with donors from different parts of Brazilian society. They donate for reasons of, altruism and solidarity. They donate for their own physical reasons of engorgement and discomfort. They donate if they, were the mother of a preterm infant themselves. There's lots of reasons why people donate, and they get to, to meet one another in this practice. So the human milk banks are forced to change their practices, and they end up with lots of other benefits. I'm going to end up with a couple more slides to say, I don't want to paint the picture that it's a utopia in terms of breastfeeding in Brazil today. I wouldn't say that at all. But I would say that there's, much wider public support for breastfeeding now, and real pushback when women have been publicly shamed or told not to breastfeed in a particular place. You've seen some of that in the United States when people have been asked to cover up or to go breastfeed in a bathroom. These are just some examples of what people had in response to moments when somebody was asked not to breastfeed in public or as public events just to raise awareness of breastfeeding, called mamasos, which we would translate as sort of nurse-ins, where people have joined in together to nurse publicly together, to call attention to the importance of breastfeeding. Sometimes they do this as well to critique the sexualization of women's bodies, to say, you should be able to see a breast without, turning it into a sexual gaze. Government support has been key to this. These are just a couple images of the fact that the Brazilian government has, decreed that it celebrates a global week of maternal breastfeeding. So they have a national celebration around maternal breastfeeding. You know how these, officially decreed national weeks are. We probably have thousands of them that we aren't even aware of, but nonetheless, there's been government support, not for these kind of cosmetic issues, but also for the milk banking itself, for the whole national chain of milk banking. And so we could ask students near the end to think about changes in breastfeeding visibility in the United States today. These are some kind of out of date images when it was first kind of making a lot of media attention that, wow, celebrities are actually talking about breastfeeding. You could probably find much more recent discussions about this, but I had these slides available. But it might lead some real reflection about Brazil, but reflection about the United States at the same time, and about these deep legacies of race, gender, and public health. So I will end it there.
Okay, well, hi everyone. Pleasure to be here. I am the program manager at the Center for Latin American and Caribbean Studies. So, sort of super behind the scenes, have participated in kind of conceptualizing this training. And, if we had held this training last year, I would have chosen a completely different way to approach this topic and maybe talk about my own research. But we actually chose it specifically because of the current events that we're all experiencing right now. So I'm kind of trying something new here. So let's do this. So racism is a public health crisis, right? So cities and counties across our nation are making this formal declaration in light of a national, but also a global reckoning on race and racism. And I'm currently presenting from Ann Arbor, Michigan, where our county declared racism a public health crisis in July of this year, around the same time that many other regions were doing the same thing. And while the first examples of racism being considered a public health emergency date back a couple of years, this particular increase that we're seeing now of declaring the emergency, which has public spending and budget implications, is happening because of the convergence of two pandemics, right? So obviously COVID-19, but also this, sort of consciousness of systemic racism. And so inquiry into intersections of race and health were really forefronted this year in light of the brutal murder of George Floyd. And so the reason we wanted to do this training was to talk more about how health and race interact similarly and differently in other regions and populations. And so these terms like racism and systemic racism have become increasingly politicized. And like I said, this new renewed racial consciousness in the US is not overwhelmingly welcomed by all. People tend to think of racism as something individual and avoidable. It's more complicated to imagine that we're all part of a system that perpetuates inequality and actually has negative impacts on people's health. So I thought it was important to use the current moment in the US to situate ourselves in this discussion. And so the first part of my talk will actually be focused on how race works in public health, and we'll use some current examples in the US. And then in the second half, we'll look at Cuba and how race and health interact there. I'm going to approach the intersection of race and health from an epidemiological perspective. I like to joke that I actually started studying epidemiology before it was cool, before it became a widely misunderstood household term, and also another politicized term in 2020 due to the COVID-19 pandemic. So lots of people talk about it, but what is it, right? Well, it's the study of the distribution and determinants of disease and health outcomes in populations. So it happens at the macro level. And it uses a set of theories and methods to find the causes of health outcomes. So unlike a doctor, in epidemiology, the patient is the community, right? And individuals are viewed collectively. And the populations we study can be neighborhoods or schools, cities, states, countries, geographic regions, or even the global population. And then the practical application of epidemiology are the measures that we take in order to control health problems. Epidemiology is just it's not just about infectious diseases like COVID-19, but it's all kinds of health outcomes like cancers and other chronic illness, foodborne illness, birth defects, domestic violence, et cetera, et cetera, et cetera. And we look at all kinds of exposures to disease like diet and nutrition, other behavioral habits, environmental exposure such as lead or pollutants, even terrorism or natural disasters. So epidemiologists are tasked with all the things, right? They're searching for the cause of disease, identifying people who are at risk, and then determining how to control or stop the spread. The term, became commonplace when we all started talking earlier this year about flattening the epidemiological curve in terms of the spread of COVID. But epidemiologists have long been informing a lot of public policy that tries to limit our exposure to things that cause negative health outcomes. So this is like taxes on cigarettes, control of alcohol and drugs, mask mandates, environmental regulations, and so on. So it's really important then to understand how race is used as a variable in epidemiology, right? When race appears to be associated or a predictor of health outcomes, we need to pay attention to this because the way in which we control for risk could have some serious human rights implications. We already know that there is potential for this kind of data to do more harm than good because it can stigmatize people in different racial groups that are shown to be, more likely to get sick. So public health professionals have long known that health outcomes look different in racial or ethnic groups. And they've long used race as a variable in their analyses. But previously, disparities have been understood through a genetic explanation. In other words, they rely on arguments that race is biological. And a common example that we still hear about today is the unequal distribution of genes that are associated with certain recessive disorders like sickle cell disease. Carrying the gene has tended to be more common in people of West African and other geographical regions, folks of West African descent, I should say. We don't have time for this in this talk, but there are actually historical and environmental phenomena that can explain why the disease seems to be associated with Blackness now. But what we now know is that biologically, there is too little genetic variation between races. So genetic explanations for different health outcomes are usually not the essential association we're looking for. And more often than not, there's no easy genetic explanation for so many of the disparities in health outcomes that we see today. Dr. Alex Stern discussed the social determinants of health, which are the conditions in which we're born and live and work. And these circumstances are shaped by the distribution of money, power, and resources from local to global levels. And they're what responsible for health inequities seen both between and within different populations. And so we know that these are typically the variables that produce different health outcomes along racial lines. You can just see some examples here on this slide. A century ago, W.E.B. Du Bois first recognized the connection, or was one of the first people to recognize the connection between societal inequities and health inequities, positing that death rates and sickness among Blacks were a matter of condition and not due to racial traits. So if race is not biological, race then is a social construct. Race is real, but the importance of racial categories is determined by social, economic, and political forces and vary from place to place. The cause of health disparities have little to do with genetics, but rather derive from systemic injustice in terms of access to resources, different socioeconomic status, access to healthcare, education, environmental exposures, social marginalization, discrimination, stress, and many other factors. So we know that the pathology underlying health disparities is systemic racism and discrimination rather than race. Race is not a proxy for racism. And so I just want to point this out because this is what we often see in health literature. And I think it's helpful if we're going to teach this in classrooms. So, public health and many health related fields are quickly moving beyond weak proxy relationships, especially in social epidemiology, which is a new field that's emerging that borrows a lot of theories and methods from the social sciences to better understand the more specific factors that influence health. So the study of race as a determinant of health has become much more of an interdisciplinary area of inquiry, and it's becoming much more intersectional, accounting for people who occupy status in multiple disadvantaged groups. And so like Dr. Alex Stern, I like definitions. So I have here, just what are we talking about when we say health disparities? They're the preventable differences of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. They're intrinsically related to historical and current unequal distribution of resources, causing groups that have persistently experienced social disadvantage or discrimination to systematically experience worse health. Health inequities is just another term that's more starting to be used more and more, and it's talking about the same thing, but the term emphasizes the implication of injustice in differences in health status between groups. So, we've talked about this a little bit today. As an example, we're all hearing about the disparities in both confirmed COVID-19 cases and mortality rates that are falling along racial lines. Both of these being, much more severe for Blacks and other people of color in the US. And, obviously, ethnicity or race is not itself the determinant of COVID outcomes, but it's this accumulation of factors, right? Why discrimination within medical systems and housing, living in safe versus unsafe neighborhoods, living near factories and being exposed to pollutants that put people at risk of respiratory illness, discrimination in employment, incarceration rates, transportation, not to mention the stressors that arise from chronic discrimination. So what we're doing here is taking a social determinants of health perspective. And this perspective, when we talk about disparities this way, it's really only useful at the population level and not the individual level. So I want us to keep that in mind. I have this definition here of racism that I thought was particularly useful for our talk. Racism specifically is the state-sanctioned or extra-legal production and exploitation of group differentiated vulnerability to premature death. And I think it's useful because it, it really focuses on the experience of the marginalized, and it's really striking to name the effect, right? The premature death, the shorter life. We know that in the US, Black folks have higher incidence of chronic diseases, higher mortality, and poorer health outcomes than any other group. And the data very well shows that Black people actually live shorter lives. So this is very striking. So we're just going to talk a little bit about the relationship between health and socioeconomic status, because it seems to be a big predictor of health. But some epidemiological studies, not all, show that health status on the macro level is more correlated with relative income distribution rather than income level. So your health is better, or your population health is better when there is a narrow gap between the rich and the poor. Population health indicators tend to be better in societies with relatively flat income distributions rather than having lots of inequality. A really interesting study in 2018 by researchers at Ohio State found that racial disparities in health actually tend to be more pronounced in upper classes because of more acute and chronic discrimination. So in other words, Black people in upper classes have poor health outcomes than white people in upper classes, and the gap is even bigger in the upper classes than it is at lower cost levels. There's other studies that show that racial health disparities cross class lines as well, like Black men in any class are far more likely to die from police violence. Black women in any class are still far more likely to die from pregnancy-related complications. And so even adjusting for socioeconomic status, Black people tend to have consistently worse health outcomes. In the study that I just mentioned, Black people whose incomes increased over time were significantly more likely to experience acute discrimination and just as likely to experience chronic discrimination. The reasons are unclear, but some reasons suggested were maybe an increased exposure to white people in more integrated settings, or maybe they were more likely to notice and therefore internalize unfair treatment. But whatever the reason, public health studies are showing that chronic discrimination experienced in one's daily life creates stress that affects internal organs and overall physical and mental health, resulting in higher rates of chronic disease, asthma, diabetes, mental health problems, and then lower life expectancy. Okay, I hope that was some useful contextualization. These are hot topics right now, and so I hope that this framework helps us understand, race and public health issues and how we talk about them across the Americas, because we do share histories of conquest and slavery and colonization. So let's go then to Latin America now. Across Latin America, Dr. Alex Stern mentioned there's variation both between and within countries in terms of income and access to healthcare. In general, sweeping generalization, poorer and darker skinned Latin Americans tend to have poorer health than the wealthier and lighter skinned. But contemporary Cuba is a bit of an outlier. Its socialist revolution in 1959 secured universal access to healthcare and removed markers of class divides. And so it provides these very valuable lessons about the links between economic justice, access to healthcare, and racial equality. The Cuban Revolution has been widely hailed for having solved, say temporarily, the race problem domestically through its Marxist revolution, and then internationally by supporting anti-racist and anti-colonial struggles worldwide. And we'll just say, well, what's true is that, you know, few social transformations have really ever attacked social inequalities more thoroughly than the 1959 Cuban Revolution. But obviously there's more to the story. So racial inequality and racism have been integral to Cuban society since the early days of the Spanish conquest. In 1509, Spanish colonizers arrived to the island, which was inhabited by a small native population, primarily the Taino people. The native population did not survive long due to war and disease brought by the European colonizers. So therefore, to replace a labor force, they brought enslaved people from Africa, and they instituted a very, very long period of African slavery beginning in the mid-16th century. Enslaved people came in especially large numbers again in the 19th century, when Cuba turned into a very prosperous sugar colony. And the sugar industry really shaped the social composition of Cuba, from property rights, labor systems, trade, even national culture and identity. And above all, the sugar industry influenced the formation of the island's race and class relations. Slavery rested on ideologies that had, and this is not just in Cuba, by the way, that had as a central premise the notion of unequal social evolution, right? This idea that whites were innately superior to non-whites. And race served to justify not only slavery, but also the exclusion of people of color from political participation and social mobility. And so Cuba is a case study in understanding the relationships between race and class, which are interwoven, but not inextricably. Although slavery globally was nothing new in the 16th century, what was new in the New World was that we had the transatlantic slave trade converging with the birth of modern capitalism, and race was constructed as the determinant of one's status within that system. And so this process constructed an understanding of race that previously didn't exist, but that we still understand today. So class divisions emerge in Cuba in a racialized hierarchy of labor, and to justify the exploitation of a cheap pool of labor, the Spanish necessarily had to find a way to differentiate groups of people. So they did so along lines that they determined to be biological, like skin color or other phenotypical traits, what we now identify more as racial lines. But to place these traits in hierarchy and to justify the ends of exploitation, the traits had to be described in a way that exemplified their inferiority. And so African and indigenous peoples were often described as brutish and savage, backwards, fit for slavery. After the abolition of slavery in 1886 in Cuba, race continued to determine one's legal and social rights, economic class, and just basically how they were judged and treated. Afro-Cubans were discriminated against and systematically excluded from higher paying jobs and politics, and they made up the majority of the island's poor and working classes. I want to make some terminology clear about what it means to talk about race in Cuba, and this is a little bit similar to what Dr. Langland was talking about in Brazil. I mentioned that much of the indigenous population died at conquest. So Cuba's population is currently made up mostly of whites of European descent and Blacks of African descent. But as well, racial mixing in Cuba was and is fairly common. The Cuban census allows for 3 different categories of skin color: white, Black, and mulatto, which is a mix. And those are the 3 categories commonly found in academic literature, but many scholars just use 2, white and Afro-Cuban, which is essentially just a white, non-white binary. But a reduction to 2 or even 3 categories does not sufficiently represent the complexity of racial identities in Cuba. Its racial system exists on a continuum between Black and white, with a mixed category that is further marked by dozens of different color terms that refer to various combinations of skin tone, hair textures, or facial features. And the specific nomenclature used for each individual combination is first a phenotypical descriptor, but also a descriptor of an individual's location in a value-laden racial society. These are fluid categories and they're negotiable and malleable. But many scholars do make a choice to use 2 categories when talking about Cuba, because the fact that people who are phenotypically of African descent tend to share similar historical legacies as well as contemporary social experiences. So Afro-Cuban is intended to be inclusive of a multitude of terms used in Cuba to describe people of African descent. It's not perfect, but it's what we'll use today. In any case, race is like kind of new in terms of being discussed seriously by the Cuban state, by the Cuban government. The Cubans' state position is has long been that by studying or analyzing racial categories, we reinforce them instead of promoting inclusion or national unity, essentially taking a colorblind approach. So Cuba's argued that there's no need to discuss race because so much racial mixture, of the Spanish and Portuguese with African indigenous populations across Latin America makes race a non-issue. But no, like contemporary scholars, many people argue that no, Cuba and Latin America are not immune from issues of race and racism. But the race problem in Cuba did become a taboo subject in academia, in the government, and among privileged white elites. The state has discouraged academic research on this subject and has only begun to systematically collect race data in national surveys. But even though they collect the data, they rarely use it as a variable by which to study social phenomena. So we don't really always know what's happening exactly. Well, anyway, equality and unity are definitely a big part of Cuba's national identity post-revolution. But this was actually something that Cuba was striving for when they fought for their independence from Spain. So Jose Marti, who's a Cuban poet and philosopher, was very instrumental in building support for independence off of his platform of racial equality, which eventually informed Fidel Castro's visions for revolution. But post-independence life was not as promised for Afro-Cubans. Spanish control was essentially replaced by another colonial force, which was the United States, which controlled Cuba after independence. And the US military administration excluded Afro-Cubans from politics, and Jim Crow policies were in many ways replicated in Cuba, though not to the extent that they were in the US. On the eve of the revolution, Cuba faced huge racial disparities in education, health, income, housing and labor markets, and imprisonment rates, but Castro promised change. With the triumph of the revolution in 1959 that overthrew the totalitarian leader at the time, Fulgencio Batista, Castro celebrated a single raceless Cuban national identity. And the revolution moved rapidly to desegregate and dismantle institutional racism. The 1976 Constitution actually explicitly prohibits any discrimination based on race or skin color. But right after the revolution, in keeping with Castro's Marxist views of history and society, Cuba relied upon the elimination of private property and class exploitation to remove the basis for racial discrimination. So Castro subscribed to the notion that removing class divisions would erase the racial effects of capitalism that we discussed earlier. And so a socialist system was put into place that redistributed land and wealth and equalized the socioeconomic status of all Cubans. Industries were nationalized, the state took control of the means of production, distribution, and prices, promoted collectivism, but suppressed any political dissent. As we all know, probably the major tenets and successes of the Cuban Socialist Project are its free and universal access to education and healthcare. So the socialist projects really did alleviate the extreme poverty and misery commonly seen in countries of similar income levels. Cuba's society is rather highly educated, with literacy rates at nearly 100%. Its reported health indicators rival those of high-income nations. But of course, the revolution was not welcomed by all. Class privileges based on private property were eliminated, and this did not sit well with those who owned a lot of property, and wealthy whites ended up fleeing to the US, right? The revolutionary measures, therefore, mainly benefited people of humble origin, thus most Afro-Cubans. All right, so let's talk about health. So as we know, Cuba guarantees the right to free education and health, both of which are the full responsibility of the state. And we'll be focusing on health in this presentation, but it is important to know that Cubans have access to all levels of education at no cost to them. So the government provides for all healthcare services and subsidizes the majority of all medication. The Cuban state, of course, controls the cost of many healthcare inputs, but it spends much less on health than other countries because it focuses on preventive medicine. In Cuba, preventive and curative services are integrated. So it's a proactive approach to health and avoiding injury and illness in the first place. It's very community-based. Cuba public health practitioners long understood that health and illness are influenced by the interaction of people with their environment, which is an early recognition of the importance of the social determinants of health that we keep coming back to. Cuban physicians were fairly well trained and respected before the revolution, but health services and facilities were mostly concentrated in the cities, and the disparity between rural and urban health was marked. In the 60s and 70s, Cuban physicians moved into rural areas so that people could access care across the country. And health indicators really began to improve by the mid-70s. So from then to now, you can see that Cuba passed through a period in which chronic diseases replaced infectious disease as the primary cause of death, thanks to things like improved sanitation and medical innovation. And as the 1970s transitioned to the 80s, Cuba expanded accreditation of medical specialties. They accelerated their investment in biotechnology, developed national prenatal screening programs, established an organ transplant program, and installed the first nuclear magnetic resonance equipment in Latin America. So Cuba's health indicators transition from those of a developing country to those more typical of the developed world quite quickly. And these indicators, like I said, are just extremely unexpected for a country with such limited resources. So while we often understand Cuba as, maybe a poorer country, which is true, there's living relatively long, healthy, and educated lives. In 1983, the Family Doctor and Nurse Plan was born, and this was a physician and nurse team that's assigned to live in the neighborhood where they practice. So literally next door to their patients. They're responsible for about 150 families each. They both take appointments and do house calls. So doctors and nurses typically spend years in a neighborhood developing long-term relationships and trust with their neighbors. Some might think that's a little intrusive to have your doctor constantly at your house, but this is the system. They coordinate medical care for their patients. They gather evidence about specific health problems in their community. And now Cuba has more doctors per capita than any other country. And so they have full population coverage under this program. That was achieved by 1999. So for specialized care, polyclinics are the next level up. They oversee 20 to 40 family doctors, the doctor-nurse teams. Those teams refer patients to the polyclinics, and then polyclinics refer patients to hospital services only when absolutely required. In contrast, in the US, sometimes depending on your insurance situation, the hospital is the first place that you can go to seek care, which is the more expensive place. So this is a cost saving and beneficial approach to healthcare. So Cuba has a fairly robust national health data collection system. It gathers data from all care levels. The information is constantly updated and analyzed at community levels in order to understand specific community health status and needs. And this facilitates local implementation of health and vaccination campaigns. On the national level, various surveillance techniques and analysis of epidemiological data take place to predict disease patterns and warn about population health hazards. So Dr. Stern, articulated this perfectly. Arguably more than anything, Cubans united around health as a part of national identity post-revolution. Cuban health indicators and medical advancements created both symbolic and real capital. Real capital through health tourism and vaccine creation, and then symbolic capital by creating revolutionary legitimacy. Cuba has, one of its major cultural products is its medical diplomacy program, previously discussed. They send aid to developing countries and regions in crisis. And so health is really where Cuba gains a positive global image that strengthens civil society, reinforces national pride, and brings in much needed foreign currency. So Cuba has seen success in creating a quality primary care and public health system, educating specialized doctors and investing in biomedical research, right? They've controlled infectious disease and reduced effects of chronic illness in a very short amount of time. And so we can see the success looking at key health indicators. 98% full immunization against 13 illnesses by the age of 2 years old. Cuba recorded one of the most rapid declines in infant mortality ever. Since 2002, Cuba's had the second lowest infant mortality rate in the Americas, which is less than half of what is observed in US Black populations. Cuba started to see improvements in life expectancy for Afro-Cubans in the mid-60s, and this trend held up, so that by 1981, the mortality differential between white Cubans and Afro-Cubans had been virtually eliminated. This is a powerful indicator of social well-being and resulted from more equitable access to health services, nutrition, and education. Today, Cuba's life expectancy is slightly higher than that of the US, and it also has less variation between racialized groups, resulting in Blacks in the US having lower life expectancy than both Afro-Cubans and whites in Cuba. So I want to take us back to a little epidemiological study. I find this this study on hypertension very interesting. I hope you will too. Hypertension is just a term for high blood pressure. So the Cuban project has really helped US researchers better understand the unmeasurable or difficult to measure impacts of racism on disease prevalence. So for example, we've long known that Black folks in many countries are at a much, much higher risk for hypertension. And even though public health as a field of inquiry understands that race is a social construct and not a biological one, hypertension had kind of remained, in the past, had remained sort of an outlier because the racial differences in exposure to risk factors were not wide enough to explain the very wide difference in blood pressure outcomes. So for a while, a genetic explanation remains more widely accepted. A few decades ago, a group of researchers wanted to be able to show that the cumulative effects of social disadvantage explained the differentials. But epidemiological survey methods that typically rely on hard quantitative data were not sufficient to prove this. So what researchers wanted to do is they wanted to test the theory under counterfactual conditions, which is to say that they wanted to test it somewhere where social equality between Blacks and whites existed. That's a very hard situation to find. So they couldn't find those conditions in any of the countries in the Americas. except for Cuba, which is a notoriously difficult place to do research, especially as it pertains to race. But in the end, they were able to. And so they wanted to test the impact of Cuban social inclusion policies. And they found consistent evidence of a diminished prevalence gap in hypertension as compared to the US, suggesting an absence of substantial racial differentials in blood pressure and laying the foundation for a better understanding of the health effects of social disadvantages that are very difficult to quantify. But what's more is that this study provides evidence that Cuba did indeed remove significant social disadvantages that actually made quality of life and health better for Afro-Cubans. And in fact, by 1987, employment, infant mortality, and life expectancy rates were better for Blacks in Cuba, Afro-Cubans, than for Blacks anywhere in the world, even in the US. So I really love to stop here and tell you that the success story of Cuba is over, and Marxist-Leninist revolution solved racism and removed racial disparities forever. But that's definitely not the full story. So Cuba did create conditions of economic justice and access to crucial resources, and that's great. But despite Cuba's achievements, the revolution did not specifically target the society's deeply ingrained culture of racism. We know that Castro favored a rhetoric of unity and equality, and his official silence on race actually contributed to the survival and reproduction of racist ideologies. Just because, they weren't openly talking about race in public discourse, racism found fertile breeding ground in the private realm, where race continued to influence relations between friends, relatives, and neighbors. So this was the clip that you were all sent, but in case folks didn't have a chance to listen, we'll listen here.
Now we want to spend a few minutes talking about Cuba's longtime leader, Fidel Castro. He died a little over a week ago at the age of 90. Earlier today, his ashes arrived in Santiago after a 4-day journey across Cuba. A private funeral will be held tomorrow morning. Many of those remembering him this week have focused on his intolerance for dissent, his crackdowns on dissidents, the media, and LGBT people. But others remember him as a champion for racial equality, both in Cuba and abroad. We wanted to hear more about this, so we called Mark Sawyer. He's a professor of political science and African American studies at UCLA and the author of Racial Politics in Post-Revolutionary Cuba. Professor Sawyer, thanks so much for joining us.
Thank you for having me.
And frankly, one of the reasons we wanted to speak with you is that we were tracking social media upon Castro's death and saw a lot of differing opinions that, frankly, seem to break along racial lines. Why would that be?
Well, because Castro has a long history with Afro-Cubans and African Americans. When the revolution first triumphed, he stayed in Harlem and met with people like Malcolm X and has a history of fighting apartheid in South Africa and having elevated the Afro-Cuban population to be the healthiest, longest living Black population in the world.
Talk a little bit more about that, if you would, and just about how Black is Cuba. I mean, officially, as I understand it, people of African descent are only supposed to be about 35% of the population, but most people think that that's just not true, that the majority of the country is actually of people of African descent. First of all, why is there even some dispute about this? And tell me more about Castro's legacy around that.
Well, the dispute is essential to Latin America, where they have a multiplicity of racial categories. So who falls into the category of Black can often be very narrow, whereas those same people in the United States would easily be considered Black people or people of African descent. First of all, the exodus of so many white middle-class Cubans opened up opportunities for Afro-Cubans. Cuba sort of didn't need initially to initiate affirmative action because there were seats available, and Afro-Cubans moved into them. They benefited from the literacy campaigns and the advent of universal education. And their life expectancy look a lot like white Cubans, and they're living almost 80 years, which is higher than the United States.
But one of the things that you argue in your book is that despite this, it doesn't mean that Cuba has actually eliminated racial disparities. Can you tell us more about that? Why not?
Well, first of all, there tended to be still a glass ceiling at the highest ministries, even under Castro, having eliminated racism. Second, as the Soviet Union collapsed and there's been less Soviet subsidies and a more market based economy, Afro Cubans have fallen behind, both because they're discriminated against in the market based economy and because a big part of the economy depends upon remittances. And most of those who went to the United States were white, and they send money back to their white relatives. And there wasn't a continued discussion about prejudice in the country. So you see a lot of things that were done by declaring racism eliminated and not having constant pressure groups in the way that we do in the United States.
Okay, sorry. that was all we needed to listen to. So in this clip, we heard Mark Sawyer talk about Afro-Cubans falling behind ever since they lost access to Soviet subsidies. Now, this is important because before 1959, U.S. was Cuba's largest trading partner. After the revolution, we know the U.S. was fearful of the spread of communism in Latin America and imposed commercial, economic, and financial embargo. So in response, Cuba aligned itself with the Soviet Union and took advantage of a privileged trade agreement. Its economy was almost totally dependent on sugar, and the Soviet Union bought 80% of it in return for Cuba's entire supply of petroleum. So the collapse of the Soviet Union in 1989 meant the end of trade subsidies and cooperation, pardon. So Cuba lost nearly 80% of its imports and exports, and the early to mid 90s were known as the special period, their time of great economic contraction, famine, and unemployment. And the Cuban government used a number of strategies to save the revolutionary project. So they opened up the island to foreign investment and mass tourism, allowed some forms of private business, legalized access to the US dollar to attract hard currency. And these capitalist-style reforms did keep the economy afloat, but they also took a toll on the foundations of social equality. Prior to the special period, the highest paid Cubans were engineers and doctors, and they earned up to 5 times as much as the lowest paid worker, a janitor or a waiter. In the current economy, a self-employed hairdresser or a hotel waiter who earns tips in hard currency earns anywhere from 20 to 50 times as much as a state-employed neurosurgeon. So this is a phenomenon referred to as the inverted pyramid. So Cuban society is becoming really polarized between those who have access to hard currency and those who do not. It's increased levels of poverty and contributed to the formation of new social classes and an increasingly visible economic elite. And it's an understatement to say that the effects of the reforms have hit Afro-Cubans especially hard. All legal avenues for accessing hard currency are connected to race. So as we just heard, Afro-Cubans receive a very small proportion of remittances coming from the US. Job competition in the new lucrative sectors of the economy, especially tourism, is fierce, but discriminatory practices in hiring abound in this new economy. White Cubans are largely employed in all of the key positions in which they can earn tips in hard currency. 2 important ways to earn hard currency are to open a family-operated restaurant or a bed and breakfast for tourists, but you need property. Afro-Cubans are relatively concentrated in areas with rundown housing, and they also lack capital to purchase a house, so these are not viable options. So they're remaining in the low-paying state sector. When Fidel Castro's brother Raul Castro took over as president, he introduced another set of sweeping economic and social reforms in 2011, or between 2008 and 2011. Cubans were granted more economic freedom as well as freedom of movement, so they could travel, which is very exciting, except that the Cuban state didn't provide any of the infrastructure to grant loans or microcredits or any other resources in order to be able to do these things. So as a result, It's just Cubans with access to private capital, again, who can take advantage of any of the new economic opportunities. Just quickly, in 2007, Spain passed legislation that offers Spanish citizenship to anyone who can claim proof of a Spanish parent or grandparent. And because of a lot of Spanish immigration to Cuba in the 20th century, hundreds of thousands of phenotypically white Cubans can do so. So then with a Spanish passport, you can live and work in the EU or otherwise secure capital to do business in Cuba. Afro-Cubans far less likely to have grandparents in Spain. So as we can see, Cuba's new economic opportunities do not start out on a level playing field. Today, most successful private businesses in Cuba are owned, managed, and staffed and frequented by white Cubans as well as tourists. In contrast, urban shanty towns are growing around the outskirts of Havana, largely made up of Afro-Cuban migrants who've come without state authorization from poorer provinces in search of informal work. The social divisions we're seeing can be witnessed in the public sector, such as in healthcare. You know, in Cuba, healthcare has been a free and universal right since the revolution, but in practice, especially now, economic strain has revealed cracks in the quality of care. So Cubans with financial, material, and social capital are finding ways to pay their way to better quality healthcare, something not previously possible. So they can either pay to visit special tourist clinics, or they can bribe low-wage healthcare workers to accept money and material goods in return for quicker and better medical attention. This can have life-threatening consequences for those without such benefits, right? Now we're starting to see these inequalities along the social determinants of health reemerge. So in summary, after the revolution, upward mobility for Afro-Cubans became possible because the redistribution of wealth and social services minimized obvious inequalities. Since the fall of the Soviet Union and Cuba's subsequent economic crisis, however, the island's achievements in economic justice and access to healthcare have been seriously affected. We're seeing rising levels of poverty, inequality, and unemployment, a drop in the quality of public health services, and now a new two-tiered system in healthcare. So the economy is changing, introducing these market mechanisms, and all of the inequalities that are emerging are along clearly visible racial lines. So while Cuba desegregated society and removed some racist institutional mechanisms, they were not able to explicitly limit structural racism because people preserved them in their private spaces. Young Black males continue to be seen as potential criminals. Perceptions of people of African descent as racially differentiated and inferior continue to permeate Cuban society and institutions. So I'm almost done here. Alejandro de la Fuente says, yet the Cubans were not able to go past their own outrage on race. Despite the massive changes discussed here, Blackness continued to be associated with negative social and cultural features. Black was still ugly. Black still meant deficit of culture and refinement, rates of schooling notwithstanding. Black was still associated with violence, rape, robbery, crime. Black continued to be Black. The justice system kept criminalizing Black youth, sending a scandalous number of them to prison. And in this regard, Cuba looked very much like the United States. Today, racial profiling of Afro-Cubans on the streets of Havana is very common. Police harass both Afro-Cubans and even Black tourists. And in light of the murder of George Floyd, significant media attention was given to the murder of 27-year-old Hansel Hernandez by Cuban police. And people are now beginning to talk about police brutality and violence and health in racial terms. So in Cuba, racial disparities in health were minimized when systemic inequalities were equalized. At the same time, many white Cubans retained advantages through ties to international capital from emigres or eligibility for a Spanish passport. But with those advantages aside, racism persisted even when other disparities were minimized. And discrimination is again creating barriers for Afro-Cubans in the lucrative emerging markets. Therefore, as the society becomes more unequal, we're seeing inequality emerge along racial lines, which directly threaten health equity. for Cuba, it also threatens the very essence of the revolution, and the island may, sooner or later start to resemble its pre-revolutionary racial reality. And so with that, I will conclude.
I think we're gonna end it there. Thanks, Alana. That was really, really great. Um, so thanks for sticking with us, everybody. We've come to our final talk of the evening, and we are very happy to have Dr. Stephen Palmer, professor of history at the University of Windsor in Canada. From 2006 to 2016, he was the Canada Research Chair in History of International Health, and he's published widely on the history of international health in Latin America and on Cuban medical science in the 19th and early 20th centuries. He's the author of Medicine and Public Health in Latin America, a history, along with Marcos Cueto, a book that's already come up a couple times in our presentations today. And he also has a new documentary feature film, Ghost Artist, about the maker of a revolutionary medical film from the 1960s. That was just released last year, I think. So, Steve Palmer, take it away.
I wanted to do a kind of a broad strokes talk, as befitting perhaps the last talk of the afternoon. And fairly streamlined one. And I thought in terms of high school, in any case, perhaps less so community college, thinking in terms of the kinds of projects that students might be able to do informally or formally to imagine public health and race and disease in as though they themselves were well-meaning progressive public health people. And public health itself has a long connection with progressive thinking, with progressive approaches to health. And so we in the current climate, I think in particular, we tend to think of race and disease in negative terms, quote unquote negative terms, because it's often, disease is often used to demonize racial others. And of course, I don't really need to go into much depth on the COVID-19 situation in the United States and the way we've shared the US president's reaction to COVID-19, demonizing it as the China virus, demonizing Chinese people as carriers, and in this case, indeed, producers of the disease and the pandemic. And of course, this goes a long way back, the way that the Chinese population in San Francisco were demonized for during the plague epidemic of 1901, I believe it was, and all kinds of irrational public health so-called public health measures were taken to quarantine that community and punish that community. And as Alana very nicely pointed out, racism is a public health crisis because, of course, one of the things that these types of demonization processes often do is obscure the real way that disease is being disseminated in a society and endangers, everybody through the propagation of ignorance. I was walking down the street in Costa Rica a few weeks ago in San Jose, in the capital, and I was struck by a public health poster in a bus shelter that said, distancing should be for health, not for xenophobia. And in Costa Rica, xenophobia we think of as not fear or hatred of foreigners, but in Costa Rica this has a very specific racial and national significance, because here it was always widely feared, sometimes with foundations of reason, with reasonable foundations, that disease is going to come from Nicaragua, and the COVID-19 situation is no different. And the Costa Rican situation in a nutshell is that Costa Rican society continues to portray itself, and again, this is a state-sanctioned portrayal, as essentially white, a country of essentially white people. And Nicaraguan immigration has been very extensive in Costa Rica since, oh, sorry, could you go to the next slide, Tim, please? So this is the poster in question. Since the 1990s, and a lot of this is illegal migration for short stints or longer stints of work, a lot of seasonal work in the agricultural sector, construction sector, but also long-term migration that's often begins illegally but legalizes itself, or is in fact legal. And of course, what this means is that over time, many people of Nicaraguan extraction become Costa Rican. And there's also a lot of people, especially in northwestern Costa Rica, who share a lot of cultural and ethno-racial characteristics of Nicaraguans, so that the demonization of Nicaraguans as these racial others, carriers of disease, carries a lot of dire social consequences in Costa Rica, because you're demonizing a large section of the contemporary population by lumping them together with illegal migrants from Nicaragua. So when the Costa Rican public health sector talks about avoiding xenophobia, what they're really talking about is discounting your understandings of race in the way you deal with this disease, and asking for you to consider national citizenship in terms and Costa Rican racial oneness, in a sense, in terms of hygienic practices. So that's sort of the backdrop to this talk. Could you go to the next slide, please, Tim? Now, in Latin America, ideas of race and nation have often overlapped, and we've heard other speakers talk about this. The way race does not necessarily factor out the same way as in the United States. And a lot of the modern nationalist, modern ideas about nations in Latin America have been built on ideas of embracing shared racial mixture over and against former notions of the white elite ruling over racially unacceptable groups who are considered to be lower in the social hierarchy. And these were Republican nation-state building models that allowed for a lot of different variants of racial mixture to be considered the same mixture, a national race. And at the same time, there's often been this formal and informal designation of certain races, as I just mentioned in the case of Nicaragua, those of Nicaraguan extraction, as essentially foreign, as not part of the nation. Now, ideas of racial mixture, mestizaje, in Latin America are themselves racist in many ways, and they codify hierarchies on the one hand, even as they promote and enable conviviality and a certain slippage and fuzziness about needing to pay close attention to racial differences in certain situations, and instead embracing racial sharing of a broad spectrum of racial overlap. At the same time, these porous borders of mestizaje do create the potential for opportunities of inclusion for racial or national groups who have been previously excluded. And what I want to talk about today is the way that epidemic disease, also endemic disease, can play a role in this over and against the more usual ways we understand of racial others being stigmatized as disease carriers and excluded. I want to talk about some cases in which epidemic disease has been a vehicle for racial inclusion. Could you go to the next slide, please, Tim? So I'm going to talk about 3 cases of these inclusionary disease dynamics. One is yellow fever in late 19th century Cuba, and we already talked a little bit about this. Alex talked a little bit about this. And Alana did a very nice overview of Cuban history in the 19th century and the way that race factored out in that process. Then I want to talk about the way that Chagas disease, hookworm disease, and malaria amongst the so-called caboclos, people of mixed European and American indigenous heritage, in Brazil during Republican nation building efforts of the 20s and 30s, acted as vehicles for inclusion of these peoples in an updated notion of a mixed race Brazilian nation, if one that was perhaps whitening over time. The idea that we need to include more people in the idea of an acceptable Brazilian national community. And finally, I'm going to come back to Costa Rica and talk again about this relationship with the Nicaraguan migrant and immigrant community and the way that the Costa Rican public health apparatus dealt with this during the cholera epidemic of the 1990s, that again was perceived by many in Costa Rican society as coming from Nicaragua. Danger that this very extremely deadly pandemic that was having disastrous consequences in many parts of Latin America was going to enter Costa Rica and threaten its national community because of Nicaraguan, dark-skinned, hygienically suspect Nicaraguan migrants. Next slide, please. Now, different diseases play themselves out in different cultural and political ways. And if there's one sort of theoretical notion I'll try to introduce here in as practical a manner as possible, because we're probably all tired of thinking in terms of conceptual categories. To think about the biological character of a particular disease, as the historian of medicine Charles Rosenberg has explored. And I'll just, rather than talk much about the biological character, which is really just the way that a particular disease, because of its biological nature, is going to play itself out differently given different political and cultural modes of the societies in which it is introduced. I'm going to talk about give you a very, very concrete example of the biological character of disease and the importance of that by talking about yellow fever in Cuba in the late 19th century. And yellow fever was a disease that was transmitted by mosquitoes, although during the period I'm going to talk about, that was not widely understood. There was one Cuban doctor who had theorized this, but he was widely considered to be a nut. But there was at the time in Cuba, so they didn't know it was transmitted by mosquitoes, but what they did know in Cuba, and where yellow fever is interesting because in most parts of the world, it arrived only in epidemic form. It was an extremely shocking and frightening disease with high fatality rates, but it was very difficult to understand it medically, including to diagnose it or understand who might get it or why. It would show up, do its damage, and be gone. But in Cuba, yellow fever was endemic, especially in Havana. And there had been large numbers of yellow fever cases going back to the late 16th century, I believe. And they knew, Cubans knew, their doctors were the most revered yellow fever experts in the world. But the population knew that if you were born in Cuba, you did not have to worry about yellow fever. And the reason was, we subsequently learned, is that you acquired immunity in childhood. You were bitten by mosquito, and if you, that have carrying yellow fever, and if that happens in childhood, you do acquire immunity to it. And so in the late 19th century in Cuba, where Cuban Creoles, and that is to say the Cuban-born white population, or population of Spanish extraction, and the Afro-descended population were combining to try to win independence for Cuba. It was still under Spanish colonial control, an extremely severe form of colonialism until 1898. Most of you will know that as the Spanish-American War, which was really the United States intervening in the Cuban War of Liberation in order to be able to arbitrate the outcome. So in the late 19th century, there are these two periods where Afro-descended Cubans joined forces with European-descended Cuban Creoles to fight for independence. And the first war is 1868 to 1878. The second one that the US intervenes in brings to a close in a attenuated form of attenuated independence, 1895 to 1898. And one of the things that really bonded the liberation forces together and marked them in a sense as natural inheritors of this land is that they did not die of yellow fever, but their enemies did, and they died in droves. That's because white merchants, settlers, soldiers, colonial administrators, they had no immunity to yellow fever, nor did the American soldiers who intervened in 1898. And this was became one of the most serious crises. More American soldiers died of yellow fever than died during the war with Spain. And this is, of course, the backdrop to the great efforts by American military scientists led by Walter Reed to discover the source, the cause of yellow fever, which they ultimately do by testing that Cuban physician's theory and devising some very artful experiments with the help of Cuban clinicians to prove that it was in fact a disease that was transmitted by the very mosquitoes that the Cuban physician Carlos Finlay had hypothesized and experimented on. But in any case, in that sort of basic way, you have an example of a disease whose biological character, the fact that it will confer immunity on you if you are bitten by the disease-carrying mosquito as an infant, can mark out a terrain with enormous political, epidemiological, and racial consequences, because here, the sort of promise of the Cuban nation, and it's very interesting, Alana is talking about the way that's still playing itself out in fraught and complex ways. But one of the promises of the Cuban nation, and maybe you can go to the next slide, Tim, was that the Afro-descended population fought side by side with the Creole independence activists, and hoped initially that the Cuban Republic would be able to accommodate both races as citizens, and this in a society very, very recently given to slavery. Slavery in Cuba is only abolished in 1886, but the first war of independence, Afro-descended slaves, free Africans led by Antonio Maceo, joined forces with European-descended Cuban Creoles, Cuban-born whites, to drive out the Spanish invaders, and later to challenge Spain again in the Second War of Independence, and then challenge the United States' attempt to occupy the island and turn it into some kind of colonial territory, and finally winning Republican independence in 1902 as a multi-racial Afro-descended, Euro-descended independence force together. And you can see in the picture of the liberation armies of 1900, I guess, being mustered out by the Americans, that there were, these were independence forces that included Afro-descended and European-descended Cubans, but very conscious Afro-Cuban sense of racial heritage informed by slavery. Antonio Maceo, the great leader of that movement, and that bargain with white Cubans. So here's an example in which the shared immunity to yellow fever, born of infancy and a telluric connection to Cuba, had really strong national and political consequences. Now, the immediate outcome of this is not very happy at all, and disease again plays a role in the Afro-Cubans don't like the way things go for them under the early Cuban Republic, and with the rebirth of an extremely virulent form of racism that echoes the Jim Crow South, and they form an independent party of color. And the white Cuban elites at this point pull kind of a fast one in a sense, because there's a lot of migration of Afro West Indians to work in Cuba at the time, and they immediately start demonizing them as bringing diseases that have been successfully expunged from the island. And there's a transference then to all Black Cubans as disease carriers, and this is part of what informs an extremely bloody slaughter of Afro-Cuban members of the Independent Party of Color in 1912. So I'm hardly proposing that this inclusionary disease model is universal, or that disease can always play this type of bonding unifying role. In any case, it's an arresting example, I think, of the kind of thing I'm talking about. Next slide, please, Tim. The next example is Cuba, is Brazil, excuse me, in the early 20th century, where there's a kind of medical nationalism in Brazil. There's a very sophisticated generation of research-oriented physicians. The most well-known around the world is Carlos Chagas, who discovers a disease. He has an eponymous disease, which if your doctor is a great, honor and testament to your brilliance. Carlos Chagas discovers Chagas disease, which is carried by an insect that lives in extremely simple mud and adobe huts of rural people in certain parts of Brazil, and infects them with a disease that over time has extremely pernicious consequences on your physical development and capabilities. But there was also a movement to identify hookworm disease, which is a worm, as you might guess, that invades the body usually through bare feet, and produces chronic anemia that makes you feel lazy, listless, nauseous, incapable of working, and also an increasing awareness of how malaria, another mosquito-borne disease, was wreaking havoc in the rural areas. And so in Brazil, you had these kind of nationalist physicians who founded a strong public health movement, and they used their medical knowledge of these, in this case, endemic diseases, more than epidemic, although in each case they could take on epidemic acuity in certain moments. They used this to reframe the people who were suffering from this disease, mixed race rural peoples who had been positioned by the white Brazilian elite as racially degenerate. And nationalist health reformers in Brazil reframed them as sufferers. These are not people who are inherently in any way inferior to any other Brazilian. They are just sick. And if you go to the next slide, Tim, there was this phrase coined that Brazil is a vast hospital, and a proposition that if you Now that we know what these diseases are that they suffer from, they can be redeemed. They can be incorporated into a new, much more inclusive, racially inclusive notion of the Brazilian nation. And the kind of folkloric figure of that is Jeca Tatu, who was the cartoon figure. It was actually a novel written by this author who's portrayed looking over Jeca Tatu's shoulder in the little graphic, Monteiro Lovato. And Monteiro Lovato, he has this novel about Jeca Tatu that's very, very popular. And it actually has 4 editions over the first 30 years of the 20th century. In the first edition, Monteiro Lovato is really a propagator of this notion that Jeca Tatu is part of this racially degenerate group. But by the final edition, he's completely, Monteiro Lovato has completely embraced the hygienist reformer discourse of redemption of Jeca Tatu through medical treatment, through public health prevention measures, the building of better housing, making sure that rural Brazilians have a latrine, that they understand the rules of hygiene, that they have access to mosquito nets, that they have access to quinine, and that in hookworm disease, for example, can be overcome in part by building latrines, in part by wearing shoes, but it can also be treated medically with a fairly simple anthelmintic or worm purge. So again, it's another example of how disease, to be pathologized is not always to be excluded. It can offer one a route for reincorporation, not one's inferiority is not something born of some essence, racial or otherwise. It's something that you're not responsible for. It's disease. It can be just treated. You can be, redeemed and included in the process. So again, a second example. You go to the next slide, please, Tim. Jumping ahead into the 1990s, and I actually lived through this. Unfortunately, I had some graphic material and I couldn't find it. But when the cholera pandemic swept through Latin America in the 1990s, it often did play itself out in terms of racial demonization. In Peru and in Venezuela, indigenous peoples were identified as dangerous carriers. They're bad practice, dirty people who weren't practicing hygiene. Again, call it the biological character of cholera, right? Fecal oral transmission. If you have clean water, you're much less likely to get it. And if you do get it and you have clean water and some very simple medical attention, you can recover from it very, very quickly. So the indigenous peoples who were disproportionately hit by cholera in Venezuela and Peru were, and disproportionately, of course, able to access potable water supplies. They were very much excluded from the national community, expelled as hygienic citizens from the national community. In Costa Rica, a very different dynamic took shape. And again, it had to do with the fear that illegal Nicaraguans were going to be the vectors of the disease. And in the process, everyone outside the part of Costa Rica where the notion of whiteness is somewhat more plausible in that, people are, there's a general light-hued mestizaje in a lot of Central Valley Costa Rican peoples. Again, it's as complex as any Latin American experience in terms of ancestry and mixing. But one thing that's clear is that outside of this core populated area of the country, many peripheral Costa Rican peoples have racially different looks, characteristics, even to some degree, cultures. And they're often Costa Ricans from the Central Valley who will often confuse them with Nicaraguans. Now, by the 1990s, this was meaningless. There were so many Nicaraguans in Costa Rica and their children who had become Costa Ricans that this type of exclusionary practice would have been disastrous. And so the Costa Rican public health authorities really strongly reactivated another notion of Costa Rican national, the Costa Rican national self-image, which is hygienic citizenship. And in a way, Costa Ricans' belief in the superiority of their own hygienic practices, which in a large degree comes from having access to a very good water supply, with the exception of today. They reactivated this notion that Costa Ricanness is not about foreigners or people of other skin colors, Nicaraguans, Costa Ricans. It's about hygienic purity. And in a sense, if you're a hygienic citizen, this hygiene, the practices of hygiene, the Costa Rican rituals of hygiene are themselves a kind of whitening process. And so all kinds of public health graphic material that was distributed showed people, especially they tempered the emphasis on racial color differences, racially associated color differences, and they did through occupation, through descriptions of occupational position. So that they had Juan, the school janitor, is there to protect the children, So of course, everybody knows this was a codification. Juan is a Nicaraguan, but Juan was just as hygienic as the school children were. And so there's this notion of incorporating Nicaraguans into this national mission, which we all shared, to practice good Costa Rican hygiene. And Costa Rica was fortunate to have a sophisticated enough water system and public health apparatus to have almost no deaths from cholera in the end. The country essentially beat the disease, even though next door in Nicaragua, things were extremely dire. So this idea that everyone who practices good hygiene can break the fecal oral chain of transmission and be good Costa Ricans can be part of the national race by virtue of having done that. Beating disease trumps racial difference in a sense, and can be kind of celebrated in an inclusive way at the level of the nation. So the next slide, Tim. Obviously, I don't want to suggest that these outcomes are absolute, and we all know and we've heard how racism remains a very strong fact of Latin American life, and there are formal and informal countervailing influences that always work to recodify racial otherness and reestablish hierarchies based on race. Nevertheless, I thought it would be interesting, perhaps provoke some thought to see disease as also having a dynamic that may enable racial inclusion. And that's all. Next slide is just excuse me, to say thank you, and hope that people still have some energy for a few questions. And no to xenophobia. I don't want you Americans being xenophobic to Canadians, and